Anita, please mute.
So we are live now. Very good evening, all respected faculties and delegates present over here. On behalf of Corona Remedies Private Limited, I Vasisht Mehta welcome you all for the Happy Learning Masterclass webinar series 109th edition in association with Bhagalpur, Darbhanga, Muzaffarpur and Gaya OBGYN societies. So for this webinar, today we have with us MOCs Dr. Suman Sinha ma'am and Dr. Apurva Kumar Datta sir. Dr. Suman Sinha ma'am is Senior Consultant OBGYN at AHIVF and Infertility Center, Ranchi, and she is Director at Advanced Care and Maternity Center. Presently, Madam is President Ranchi OBGY Society and she owned many awards and accolades into her account. Welcome, ma'am. To accompany her, we have young and dynamic personality Dr. Apurva Kumar Datta sir. Sir was the national coordinator for Foxy's CME and workshop for safe abortion and contraceptive cafe 2020. He is national coordinator public awareness for Foxy Sexual Medical Committee. Welcome Apurva sir. Today we have coordinators Dr. B. Kalpana ma'am and Dr. Jyoti Banglowala ma'am. Dr. Kalpana ma'am is consultant gynecologist and infertility specialist at Guru Hospital and currently she is secretary at Madurai OBGYN Society. Welcome you ma'am. Dr. Jyoti Banglowala ma'am is presently secretary IUGS and has rich experience of 26 years in the field of gynecology. Welcome you ma'am. So we begin our session with lamp lighting. So with this, I would like to invite Dr. Suman Sinha ma'am and request her to please take us through her academic journey. Over to you ma'am.
Thank you, Basisji, for your very kind introduction. Good evening and pranam to one and all. Now, on behalf of Happy Learning 109th webinar series, I welcome our chief guest, respected Dr. Rangila Sinha Madam, the icon of Bihar and Jharkhand. Thank you, Madam. And then I welcome our guest of honors, my teacher, past Vice President Foxy, Dr. Anita Singh Madam, Dr. Beena Sinha, Professor and HOD, Bhagalpur Medical College, our Program Director, Dr. MC Patel Sir, our conveners, Dr. Sneha Bhuyar and Dr. Asa Jain, our very learned and experienced speakers, Dr. Kumudni Jha and Dr. Pratibha Singh, and none other than Dr. MC Patel, our very experienced moderator, Dr. Vibha Verma, and Dr. Sweta. I welcome all our chairpersons who have kindly consented to be with us for the inputs. I welcome all the panelists. They have prepared very hard. I see they are learning. My friend Lata, I can see here. And I welcome all the esteemed delegates who have joined today. I really feel honored to have the opportunity to welcome you all. I welcome my coordinator, Dr. Kalpana and Dr. Jyoti Banglowala, the co-MOC, Dr. Purva Datta, and we are really very happy to have all of you on board. Thank you, everyone. And now I would like to invite and welcome Dr. Asa Jain. Can I have Dr. Asa Jain's CV? As we can see here, Dr. Asa Jain is past president, Raipur OB-GYN Society. Presently, she is honorary secretary, IMA Raipur. She is also secretary, Rotary Club of Raipur North. And presently, she is director of SMSA Hospital. Welcome, Dr. Asa. I would like to request you to welcome and invite our program director, Dr. MC Patel, sir, for the welcome address. I have not seen Dr. Asa here. Sir, I request you.
Ma'am, she is not there, ma'am.
Yes. So I request Dr. MC Patel, sir, for the welcome address.
No issue. Yeah, yes. Can I request Sneha, ma'am?
Yes, yes. In fact, please, In fact, it's my proud privilege to introduce respected Dr. MC Patel, sir, who is the brain behind the entire program of Happy Learning, which is going on successfully for the last 108 episodes, and this is the one additional. Sir, all of you know as the medical legal expert. I'm sure every Foxian knows him, and the way he helps people for as far as the medical legal aspect is concerned. Sir was a vice president of Foxy, and he was a chairperson of Ethics and Medical Legal Committee of Foxy. So was the organizing chairperson of MMCon 2018. He was an honorary member of National Inspection and Monitoring Committee, PNDT Act, and of course, all of you know him as a major contributor for the uniform consent for Foxy, which is just prepared, and the tenure of Dr. Alpesh Gandhi, sir. So with this, I present to you Dr. MC Patel for his official welcome address. Over to you, sir.
Thank you, Sneha. It gives me immense pleasure to welcome you all on 109th episode of Happy Learning Masterclass web series. And I am also happy to invite all the society who have joined this webinar, Bhagalpur, Darbhanga, Gaya, Magad, and Muzaffarpur. I welcome Dr. Rangila Sinha Madam. Many times mere presence of a person like Rangila Sinha Madam is enough to inspire us, to encourage us for this type of academic activity. And I am lucky enough. She is always kind to me. As far as any of my academic activities are concerned, she is always with me to encourage me. So welcome, Rangila Sinha Madam. I also welcome Dr. Anita Singh Madam, immediate past Vice President of Foxy and President of AOGS BJ. So welcome, Dr. Anita Singh Madam. She is very busy person, but still she have kindly consented to guest of honor to bless us. I also welcome Dr. Bina Sinha Madam, Senior Gynecologist from Bhagalpur. She has also kindly consented to be guest of honor to bless us. I also welcome two learned speakers, Dr. Kumudini Jha from Darbhanga and Dr. Pratibha Singh from Bhagalpur. All these members who are present here, I was lucky to meet all of them almost on Saturday, Sunday at Bhagalpur only. So congratulating all of them for a very successful conference of AOGS BJ at Bhagalpur. And I cherish very sweet memory of that conference also. So welcome Dr. Kumudini Jha and Pratibha Singh Madam. I also welcome two learned moderators, Vibha Verma Madam and Dr. Sweta Kumari from Muzaffarpur and Darbhanga respectively. and they are going to discuss very important topic, troubleshooting in a placental abnormality. Kumudini Jha madam is going to discuss abruptio, and Pratibha Singh madam is going to discuss adherent placenta spectrum. So today we have decided to discuss focus topic, placenta, the magic organ. I also welcome our two learned expert panelists, Dr. Sneha Buyar and Dr. Rekha Rajendra Kumar. Both are with me in this series. So welcome Dr. Sneha and Dr. Rekha Rajendra Kumar. I also welcome all the learned panelists. Dr. Varsa Nigam madam from Bhagalpur, Dr. Roli Bharti from Bhagalpur, Dr. Supriya from Darbhanga, Dr. Asurani from Muzaffarpur, Dr. Sadhna Sinha from Muzaffarpur, Dr. Sunita from Gaya, Dr. Roma Yadava from Bhagalpur, and Dr. Jamurad from Darbhanga. I also welcome all the learned chairperson who have kindly consented to chair respective session. Dr. Anju Turier from Bhagalpur, Dr. Bharat Prasad sir, he is unable to join, but he had a phone call to me and he has blessed us for all the success of this webinar. So in his absence, we welcome him also. I was lucky to interact with him during my visit to Bhagalpur for AOGS BJ. In spite of this much seniority, he is very kind enough to discuss any topic to anybody. So I acknowledge this. I also welcome Dr. Ramadhar Tiwari sir, very senior person from Magad. He is also here to bless us and to chair one respective session. I also welcome Dr. Maya Shankar Thakur from Darbhanga, Dr. Rekha Jha from Bhagalpur. What can I say for Dr. Rekha Jha madam? She was a person of this conference of AOGS BJ, of course, with Roma and Dr. Kiran and with Dr. Pratibha Singh madam. And it was teamwork, I can say, under able leadership of all these stalwarts from Bhagalpur and other districts. I also welcome Dr. Prachi Singh madam from Muzaffarpur. I also welcome Dr. Kavita Barnwal from Bhagalpur. I have seen Kavita during those conference moving from here to here to make this conference not only successful, but all the delegates' comfort she was looking after. So hats off to Dr. Kavita. I also welcome Dr. Prabhati Kesri from Bhagalpur, young gynecologist from Bhagalpur. She was also very kind to me during my visit to Bhagalpur. And Dr. Lata Shukla madam from Magad. I had a interaction with Dr. Lata Shukla madam also, and she have already invited me to visit Magad, and I couldn't resist to say no. So at any convenient time, it will be my pleasure to visit Magad and Gaya. I also take and acknowledge a role of Dr. Sneha Buyar and Asa Jain as a convener, Dr. B. Kalpana and Dr. Jyoti Banglowala as a coordinator, and Dr. Suman Sinha and Apurva Datta as a master of ceremony. So again and again, as far as this conference of AOGS BJ is concerned, all the stalwarts from Bhagalpur and other societies, they had left no stone unturned to make this conference very memorable and successful, and as far as hospitality is concerned. So it was par excellence. One evening, we had been invited for dinner at Pratibha Singh's madam home, and next day, high tea at Dr. Vasundhara Lal's home. It was a very nice experience to interact with, other than gynecologists, so many people from Bhagalpur. It was very special experience as far as this meeting with all this legion from Bhagalpur is concerned. They, of course, they are in public life, but it was very nice interaction with all of them. So welcoming you all, let me put in Kora at the era of COVID-19, when physical meetings were not possible. Of course, now physical meetings are already started, and we have witnessed just AOGS BJ also. So in those days, we started this webinar to meet our Foxian friends and to discuss focused topic. Ultimate goal was to be helpful to our gynecologist friend, to update their knowledge and to be helpful ultimately to our patient, because ultimate goal was to check maternal mortality and infant mortality was the aim. Because by 2030, government and WHO has given us a target that maternal mortality should be less than 100, it should be by 76, and infant mortality should be 12. And if we go hand in hand, government, NGOs, a federation like Foxy, IMA, and we obstetrician, and particularly working in rural area, rural remote area, if we go hand in hand, then that goal we can achieve. So with this aim, we have started this series. And again, I welcome you all. And I also welcome all the president and secretary of respective society who have joined this webinar, Bhagalpur, Darbhanga, Gaya, Muzaffarpur. So welcoming you all. And again, heads off to all the legends from Bhagalpur, Dr. Rekha Jha Madam, Dr. Roma Madam, Dr. Kavita Madam, Dr. Pratibha, and all the legends. I welcome you all. Thank you. Thank you very much.
Thank you, sir. Now I take the opportunity to invite and welcome our convener, Dr. Sneha Bhuyar, Madam. Can I have her CV? Madam was a very dynamic past chairperson of Breast Committee, Foxy. She is presently Governing Council member, ICOG, for 2021 to 2022, and chairperson Medical Disorder Committee, AMOX. She is recipient of many awards and accolades. Her research work has been published in more than 27 national and international journals. She has been invited speaker in more than 300 state, national, and international conferences, and has more than 30 years of experience in the field of obs and gynae. Madam, I request you to invite and welcome our chief guest, respected Dr. Rangila Sinha, Madam.
Thank you, Dr. Suman, for that kind and generous introduction. A very good evening to respected Madam Rangila Sinha, Madam Anita Singh, Dr. Beena, and respected Dr. Ramadhar Tiwari, all the respected faculties and the delegates. A very good evening to you. In fact, it is my proud privilege to introduce Madam Rangila Sinha, such a illustrious personality with a highly decorated CV. Madam is the former president, former professor and head of Obs Gynae SK Medical College, Muzaffarnagar. She was a vice president of Foxy and a chairperson of Public Awareness Committee, Foxy. And Madam was the founder, president of Muzaffarnagar Society. Of course, she is a founder president of Association of Obs Gynae Societies of Bihar and Jharkhand. And Madam has many papers and research, national and international conferences to her credit. And her area of interest is urogynecology and safe motherhood, especially. So it will be, we will be highly obliged and blessed to listen to you, Madam. Over to you, Madam Rangila Sinha.
Rangila, Madam, you are
Madam,
muted.
please unmute. Please unmute. Unmute. Yeah.
Can you hear me?
Yes, Madam.
Yes,
Now.
ma'am. Yes,
Thank you very much, Dr. Sneha, for your nice introduction. Thanks goes to Dr. MC Patel and his team for this organizing this happy learning immediately after AOGSBJ conference. See, I see this learn this webinar as a practical aspect of AOGSBJ, because you are accumulating these districts, doctors from districts and regions of AOGSBJ. And in that way, you are making our task easier. And Dr. Anita, your task much more easier, because every time this type of conference will be there and we will be meeting and this local district doctors will be meeting, they will be acquainted with each other. So our task is going to be much easier. In that, I thank you all, Dr. Patel and your team for this, your activity.
Thank
Are
you.
still in the I am still in the aroma of AOGSBJ conference.
Yes.
Thank you,
and everybody, I think that every speaker is going to say something about this AOGSBJ conference. This AOGSBJ conference this time, I think it was more academic than social and entertainment. First of all, I have labored so much about this award session. So I will be talking about this Dr. Rangila Sinha Young Gynecologist Award session. For me and for the participants also, it was very fulfilling this time. The cause appears to be more enthusiasm created by organizing committee in Bhagalpur, because I started informing about this award and giving information about the criteria and people, inviting people and different society. So there was a wave of enthusiasm and happiness and interest created in all the young gynecologists. And one day, Dr. Rekha Jha phoned me, "Madam, this appears to be very interesting that every day I'm getting 3 or 4 inquiries that how it will be happening and how we'll participate." So in that way, I think that I was very happy with this award session in Bhagalpur. And here, I think a real research and academic environment was created, both by the participants and by their presentation and by the interaction and guidance of the participants by judges. So this was actually the research and academic environment was created. The last day on 13th, I never expected that so many people will be will come in the results section, and all were, most 3/4 of the participants of previous day also, they were there, and audience, and even Dr. Rekha and all the organizing persons came, and they were so happy. Dr. Rekha was in dancing mood. That's why I asked him how you have got so much energy left just for the last session. In this session, I will just want to mention one first paper. First paper was by Dr. What was her name? Yes. What was her name? I am just forgetting. And her paper was very impressive because she was talking on the effect of environment on the fetus, and in the adult life also, what disease is much more common if there is environmental factor during pregnancy. And she answered cancer lung, and the examiners were very happy. So she got first prize, and second prize was also very impressive.
Dr. Ujjwala.
His isolation of HPV from this menstrual blood was very impressive, and I think it was very interesting, and actually research type of these two papers were real research papers. So with these applauds to all these persons who participated, who made it so successful, now I want to switch over to another aspect of my talk, that is as a chief guest. As a chief guest with such a long experience, both in academic, in clinical, and in day-to-day behavior and of the doctors, of students, what should be actually the real importance of life is standing at this juncture of my life. When I look back, then I think that what is so important in your life. My suggestion is that you should just fulfill your requirement so far your physical requirement is concerned. You will be surprised to know that I have got only one house in Muzaffarpur and another is in village. That is my paternal house. Apart from that, I never tried to purchase any land, any house in any of the town because it was not required. And up till now, I am feeling that it was not required. So your fulfillment of requirements should be at a limit. And that limit should be first in your physical requirement, not your academic requirement. Your academic requirement should never be fulfilled. It should be always, you should be hungry that what I know is very less. I should know much more and more. So that is my experience up till now, that your academic requirement should never be achieved, but physical, there is no need of going beyond. Don't be, as medical graduates, young gynecologists, young doctor, you should be always satisfied and first try to obtain maximum knowledge, then try to go in public and try to first don't think that I have come in medical profession just to earn money. You have come in here to gain knowledge, to serve people, and that what you will get, that is byproduct. Automatically people will give you. You don't have to ask. I never asked anything, but I got everything. And at this juncture, I think that money does not matter, physical achievement does not matter. What matters, that is your academic activity and your attitude towards others, helping others. And that activity will maximum pay in long run. So that should be the aim of a doctor. When it comes to money and acquiring wealth, I think that I should never die. I should die today. But when it comes to acquire knowledge, I should die young. I should never get old. And that is my wish. And I want all of you wish this. With this, I give you your blessing that you should be much more active at 85 years than what I am. Thank you.
Thank you very much, Rangila Sinha Madam. Your presence is enough to encourage us, and your words of wisdom. We are always blessed with those words. Thank you. Thank you very much, Madam, for sparing time to bless us.
Thank you, Madam. Yeah. I again request Dr. Sneha Bhunar, Madam, to welcome our guest of honor and introduce.
Thank you so much, Rangila ma'am, for that blessings. And of course, we also could feel how proud you must be feeling, your small sapling growing into a huge tree, the society which you have founded. So really, we appreciate all your efforts, and thank you so much once again. So now I welcome Madam Anita Singh. Madam is the ex-professor of Patna Medical College, and all of us know that she was vice president of FOXI, chairperson of Endocrinology Committee of FOXI in 2014 to 16, and she's a past president of Patna Gynae Society. She was a governing council member of ICOG as well from 2015 to 20. Madam was organizing chairperson for UFOX in 2011, organizing secretary for AICOG 2014, and she was also the organizing chairperson for ICCOB at Patna. She has contributed many chapters in the books and of course lots of publications as well. Above all, I would say Madam is a very humble and a very good human being. I have experience working with her when she was a vice president, and I was a national coordinator for the very noble cause of rooting out the cervical cancer. So we had a pan-India program for eradication of cervical cancer. So we'd like to hear to you, Madam, for your pearls of wisdom. Over to you, Madam Anita.
Thank you, Sneha, for your nice introduction, and we do remember the golden days when we worked together for FOXI, and still will be working in the future, even if I'm not holding any post. And of course, I am there to help you in whatever endeavor, whichever position you reach. I think we'll work together.
Thank
So,
you,
first of all, I wish to thank Dr. MC Patel for organizing this program for 4 societies from Bihar. And I know the standard of academics and clinics are increasing every day and night in Bihar and Jharkhand. We had been lacking behind till a few years ago. We have taken maximum advantage of the webinars that has taken place. And I feel by the prescriptions coming to me every day as a cross consultation that the standard of practice has improved all over, and more so over in Bihar and Jharkhand. So I'm very proud and very happy about it. And gradually the people are taking more and more interest in academics, and we see the attendance in any of the conferences or webinars. It is very good. And even the people, those who are in the remote places, are attending all these webinars, and they are gaining quite a lot of knowledge that helps them in their clinical practice. Regarding Dr. Patel, he is a good organizer. I know him from very long time, and he had come to Bhagalpur at the time of my installation. He was there. So thank you, Dr. Patel, for being there in our conference. And I don't have any word to praise Madam Dr. Rangila Sinha, because I have been, because whatever I am today as president of AOGS BJ, it was the blessings, love and affection of Madam for me, who has given me this post. And I hope I will prove her to her expectations, and I will work with the help of all the societies and all the members of FOXI and the office bearers of FOXI will help me in my journey as a president AOGS BJ. And regarding this program, this is a very well program which is.
Madam, you are not visual.
No, we can see her. We can see her.
Yeah. Please continue.
Carry on. Anita Singh, carry on.
Okay. Today's program, actually, I didn't go through the program earlier, but I just now came to know that it is on placenta, a very favorite topic and very essential topic. As I said in my inaugural address, my first priority will still be to lower maternal mortality and parental mortality. And I think the knowledge of placenta and the placental problems are going to help us in both of these conditions, if you do have a good amount of knowledge about it and how to, as I said, how to prevent and manage when it happens. Both the abnormalities of placentas as well as this placenta accreta syndrome are very serious conditions. In placenta accreta syndrome especially, we all are very much scared. So we must prevent it from occurring if possible. If not at all, correct diagnosis and proper referral of the patient to the proper place in time goes a long way in the management of these patients. So that is a very important topic. I think it must have been chosen by Dr. MC Patel himself, because he is a very practical person, and the speakers are also very good. And all the members whoever are attending this program are going to be benefited from the discussions that will be following after the inauguration. And I don't want to waste any time between the academics and this inauguration. So thank you very much for calling me as a guest of honor. And I wish all the success for today's program, as well as for the people who have organized this program. Thank you very much.
Thank you very much, Dr. Anita Singh ji, to spare time to bless us. Thank you very much.
Thank you, Anita Di. Now I have the opportunity to welcome our second guest of honor, Dr. Veena Sinha, Madam. Dr. Veena Sinha, though she has got a very long CV, but she has here it is shown as his retired professor, Medical College, Bhagalpur. It speaks a lot of volume. This one line has a lot of volume about her. So I welcome Dr. Veena Sinha, Madam, and we need her blessings. Is Madam here? Since I don't find here, we move on to the academic session.
Ma'am, she is not here.
So
Madam is not here.
we can proceed accordingly, and when she joins, we will have
Yeah,
blessings.
we'll have we'll listen from her.
Okay.
Take her blessings. Now with this, we move on to the academic session, which is on placenta, the magic organ. And the first topic is on abruptio placenta, and we have speaker as Dr. Kumudni Jha. And now I request Dr. Apurva Datta to introduce our very learned chairpersons, Dr. Anju Turiya, Dr. Bharat Prasad, and Dr. Ramadhan.
Thank you so much, Suman ma'am. At the outset, I would first congratulations and thank you, MC Patel sir, because he's always bring the topics we are actually the nightmare of every obstetrician, and beautifully executed. He's giving how to deal with that. So thank you so much, sir, for choosing those very important topics. So and after the blessings of the seniors, Rangila madam, Anita madam, now it's the time to start the scientific session. And for chairing the first session, I would like to invite the chairperson, Dr. Anju Turiya ma'am, a very dear level senior of ours. Ma'am is an MBBS DGO, just immediate past president, Bhagalpur Society, and director of Matratva Clinic, Bihar State Coordinator of Swasth Nari, that is Cancer Prevention Program, Vice President of AOG BGH, and Zonal Coordinator of the Family Planning Committee and whatnot. Thank you so much, ma'am. Welcome you. Now the next chairperson is Dr. Bharat Prasad, sir. Yeah, sir is DGO, MS, FICOG, visiting professor at Chitwan, Nepal, former professor of Darbhanga Medical College, Santosh Medical College, Saraswati Institute of Medical Sciences, Hapur, and the organizer of the 5th annual conference of AOG BGH, the vice president of vice president of AOG BGH, and whatnot. Thank you so much, sir. As MC Patel sir already stated, he is not present due to some emergency. So we have the blessings of sir. Next, our chairperson is very senior, very, I can say he's an encyclopedia himself, Dr. Ramadhan Tiwari sir. Sir is the past president IMA Gaya, past vice president IMA Bihar, founder president of the Magadoji Society, organizing chairperson of the 7th AOG BGH Conference 2016, and life member of Red Cross Mangalam. So thank you so much. Thank you for coming here and give your precious time. Since Dr. Bharat Prasad sir is not present, can I have Dr. Ramadhan Tiwari sir, I request you to please insight and introduction about the placenta previa, sir.
Good evening.
Damodar sir.
Respected
yes,
our chief guest, Rangila madam. Just now, Rangila madam talked about the basic ideas of the life. So whatever she speaks, just like the mantra of the Gita. Next is Dr. The guest of honor, Dr. Anita. She is present president of AOGSBJ and a stalwart person of the Bihar and Jharkhand. Next is Dr. Beena Prasad, my classmate. Actually, she is not here. Then Dr. MC Patel, who is actually the pioneer of all this program. And then the Dr. Rekha Jha, Dr. Pratibha, and other very senior persons of the ABGS society, and the persons from the in the panelist, the organizer of this program, the Corona Remedies people, ladies and gentlemen. Actually, I am thankful to the association and actually the Madam Suman Sinha. Actually, they have chosen this very important topic, and that is the placenta, the problems of the placenta. Now, I can give one example. When I was head of the department of OBGY in Sasaram, then I asked my one colleague, very newly appointed colleague, कि आप जाके एक क्लास ले लीजिए. So she went there and कही कि अब सबसे बढ़िया क्लास लेना तो bleeding disorder in pregnancy ही है. तो लड़के ने कहा कि नहीं, early pregnancy नहीं, late pregnancy बताइए. When she came, she told me, I have taken the class of placenta previa. I told her, why you have not taken the abruptio placentae? कहा कि सर, जब मैं लेके आती हूँ तो मैं प्रणाम करती हूँ कि प्लेसेंटा abruptio placentae का केस ना आवे, क्योंकि उसका डायग्नोसिस भी गड़बड़ है, उसका काउंसलिंग गड़बड़ है, उसका सब गड़बड़ है. So when you choose about the placenta previa and abruptio placentae, it is better to talk on the placenta previa than the abruptio placentae. But I think the speaker of today, Dr. Kumudni Jha, will justify the and will solve the problems of the abruptio placentae, because this is very, very important, because it is not only problematic for the fetus, it is problematic for both mother and the fetus. So I think not to take much time. Thank you very much, Dr. Prabhu.
Thank you so much for giving the introduction and sharing such a beautiful experience. So I would like to invite Anju ma'am to introduce our speaker, very lovable senior Dr. Kumudni Jha ma'am.
Thank you, Apurva. First, I would like to thank Dr. MC Patel in person, especially for having me on this dais. I also extend my warm regards and welcome to all my seniors, juniors, and friends. And I bring greetings, fresh greetings again from Andhra Pradesh. It's a happy moment for me to introduce Kumudni. I also want to convey my regards to Rangila ma'am, Anita ma'am, Beena ma'am, and all Dr. Sneha Bhuyar, and all Dr. MC Patel especially, and all my juniors and colleagues. Now, without wasting any time, I would like to go to the CV of Kumudni ma'am. Dr. Kumudni Jha, she was a very nice friend of mine, quite senior, but a very loving person, a very nice friend, and soft spoken. In the college days, we used to give her a nickname. We had not actually given. It was given by her colleagues, classmates. She was called Madam Churi of her class. So it's a proud thing to be called after such a person. Now, going to her introduction, she actually needs no proper introduction. Everybody knows her. And she herself is an encyclopedia of knowledge. She is MD, PhD from DMCH and ex-HOD Ops Gynae from Darbhanga Medical College. She has got publications in national and international journals, been a speaker in several CMEs, conducted several seminars, presented several papers in state and national conferences, She's been an examiner of undergraduate and postgraduate candidates and the clinical secretary of Obs and Gynecological Society, Darbhanga. Kumundi Di, I welcome you on stage to give out your knowledge and share it with all of us.
A very good evening to everybody, and thank you so much, Anju, for those kind words, which I don't think I really.
Your topic is very complicated and a very difficult one. I mean, the condition is very difficult one, and I think you'll give full justice to it.
Dr. Kumudni, could you send the slides to me?
Yeah, I've sent the email.
To me?
To you and to Vasisht.
The Vasisht will do. I think he will do.
Okay. Ma'am, working on it. Just give me 1 minute.
Yeah, okay. We are giving you.
Okay, no problem. Thank you so much, Anju, for those kind words. And Sir, Dr. Ramadhar Tiwari, sir, he was head of the department here. And I'm so obliged to him for whatever he has taught us. And thank you so much for the words that you've said for me. At the outset, I must thank the director of this program, the Happy Learning series, Dr. MC Patel. I met him at Bhagalpur just recently. He's of such a humble demeanor, and he does his work so silently. And he's done such a great work, which no politician, I think, can have done. He's unified the whole nation, all the Foxians, right from north to south, east to west. Every small society he's taken care of. Hats off to you, sir, for all the efforts you're putting in. And I think we need such a leader for our organization to take it further in future. So thank you so much, sir. And this topic that has been allotted to me, that is abruptio placentae, which is a very treacherous condition, as Anju was just referring to, that I think each and every one of us have faced at some time or the other in our life. Hello. Next slide, please. So by definition, it is any painful bleeding per vaginum after the age of viability of the fetus. It is 28 weeks in India and 20 weeks in the advanced countries to delivery with varying degrees of placental separation. The prevalence is 1 in 200. Next slide, please. So the etiology is generally unknown, but there are some risk factors like a patient with a placental abruption in a previous pregnancy not caused by trauma. In one previous abruption, the chances of recurrence is 15%. 2 previous abruptions, the chances go up to 25%. Patients older than 35 years or younger than 20 years are at high risk. Chronic hypertension and related complications like PET, HELP or eclampsia, multiple pregnancy, polyhydramnios, especially with a sudden rupture of membranes because of sudden decompression, and GDM, chorioamnionitis, amniocentesis, especially when it is not done under ultrasound guidance, we may puncture the vessels, and subchorionic hematoma, those with thrombophilias, patients with, we know that high AFP levels lead to 10-fold rise in abruptio placentae. Placenta on the uterine septum or a sick placenta diagnosed on Doppler, torsion of the uterus, a short cord, and even a male fetus, of course, the cause of that is not explained yet, tobacco and cocaine intake. Next slide, please. So to prevent, we can only prevent the risk factors like early detection and treatment of hypertension and its complications like eclampsia, HELP. Amniocentesis should be done under ultrasound guidance, and which all of us are doing, of course, now. Avoid sudden decompression, like when you're rupturing the membranes of a polyhydramnios patient, do a little high rupture, and let the liquor escape slowly, and avoid supine hypotension. Folic acid supplementation has been seen to decrease the chances of abruption, and of course, the avoidance of substance abuse. Next slide, please. So the pathogenesis, there's a premature placental separation, which is initiated by hemorrhage into the testicular space, leading to blood collection, followed by degeneration and necrosis of the placenta adjacent to it and causing infarction of the placenta. There are different manifestations of hemorrhage. It could be a concealed type, which usually happens in 20 to 35% of patients. The blood totally accumulates behind the placenta when the placenta is fully separated, except at the margin. In USG, it appears as a retroplacental collection between the placenta and the myometrium with the worst fetal prognosis, a mortality rate of around 50%. Revealed hemorrhage that occurs in 65 to 80% of abruption patients Blood dissects between the membranes and the uterine wall and out through the cervix. It may remain obscured due to pressure by the fetal head. On ultrasonography, it appears as a subchorionic hematoma with a low fetal mortality of 10%. Blood percolating into the amniotic cavity, rupturing the membranes is another manifestation. Ultrasonologically, it appears as a pre-placental collection, that is subamniotic hematoma. Covillia uterus, that is percolating of the blood into the myometrium, and that occasionally leads to atonic hemorrhage. Next slide, please. So we have to differentiate between the clinical difference. There's to be a clinical differentiation between revealed and concealed type of hemorrhage. The character of the blood, the color is different. It is dark and continuous in revealed type. Abdominal discomfort is much more in the concealed type. It is acute and maybe intense. Pallor is disproportionate to the loss of blood that you see outside. PET is usually associated with concealed hemorrhage. Uterine height, that is again more than the period of gestation in concealed hemorrhage, whereas it is proportionate to the period of gestation in revealed hemorrhage. The feel of the uterus, that is tense, tender, and typically cardboard rigidity type in the concealed type of hemorrhage. Fetal parts, therefore, may not be felt in the concealed type, and the FHS also is usually not located. But you can hear it in the revealed type unless there is an IUD. The urine output is usually diminished in the concealed type. In severe cases, it may lead to even renal failure. Hemoglobin is significantly low and out of proportion to the loss of blood. Coagulation profile is disturbed and disrupted in the concealed type. In the setting of DIC, the CT is more than 6 minutes, fibrinogen less than 150 milligrams per deciliter, platelet count is low, there's an elevated APTT, and an increased FDP and D dimers are seen. Proteinuria is usually present in the concealed type. Next slide, please. Next slide, please. So the clinical caveat is that you have the differentiation from placenta previa is done because in the concealed type, we know that severe gynecological and obstetrical complications are sealed. And even the presence of shock is usually common in the concealed type. It is mild when 15% of the blood has been lost, moderate when 15 to 30% are losses of blood, and that is associated with tachycardia, hypotension, and reduced mean arterial pressure. In the severe type, 30 to 40% of loss is associated with the features of unstable BP and urine output. Next slide, please. Now, according to the degree of separation, there's another classification. Detachment of the entire placenta occurs in 7% and partial separation in 93% of cases. This may be graded as 0 grade when the bleed is mild. A small hematoma is there. In 40% of the cases, they have a bleeding, which the vaginal bleed is there and uterine irritability is there, but the fibrinogen levels are normal. In 45% of cases, there's vaginal bleed, uterine tenderness is present, and the maternal pulse is raised, and the fibrinogen level is also below 150 milligrams per ml. Grade 3, in 15% of cases, there's severe vaginal bleeding, and there's persistent abdominal pain. Maternal shock is there, and after DIC, the fetal distress and IUD also may be there. Next slide, please. So to diagnose, generally this is because of clinical features, and that is what we usually do when the patient comes in the dead of the night. You don't have an ultrasonologist by hand. So by the clinical features, what do we note? The general condition of the patient, pallor, blood pressure has to be noted, urine output has to be seen, so Foley's has to be introduced immediately. Amount of bleed has to be seen and it has to be quantified. Uterine tone, you see whether it's hard or not, fetal parts are palpable or not, and whether the FHS is heard or not, and what is the height of the uterus, whether it's corresponding to the period of gestation or not. Corresponding with the duration of gestation, and if it is there, then and the bleeding you can see is quite prominent, then it could be a revealed type. USG is usually helpful in diagnosing retroplacental collections. It may be confused with a thick placenta or a fibroid. In the revealed type, it may be confused with placenta previa or the indeterminate causes of vaginal bleed. In the concealed type, the differential diagnosis has to be done from ruptured uterus, rectal sheath hematoma, appendicular or intestinal perforation, twisted ovarian tumor, because in that also there's severe pain and the patient may be in shock, or volvulus, acute hydramnios, and tonic uterine contractions. The significant points in diagnosing abruptio are shock out of proportion to the amount of the external bleed, presence of PET, uterus is tense, tender, woody hard, FHS may be absent, low urine output, and the coagulation profile may be altered. Next slide, please. And from the placenta previa, the differentiation has to be done, especially in the reveal type. So in this, the abruptio, in placenta previa, it is a painless fresh bleed, but in abruptio, it is painful and usually dark color. Color is proportional to the blood loss in placenta previa, and in the concealed type, it may be disproportionate. PETs, again, we know, usually present in 1/3 of cases of abruptio, and the uterine height will be disproportionately large in the concealed type, and the feel will be woody hard as compared to the soft feel of the placenta previa. Malpresentations, they are usually present in placenta previa because it occupies the lower segment, and it is unrelated in abruptio. The FHS is generally present in placenta previa unless there has been heavy bleed, but in abruptio, it is generally not heard. The placenta is low here and it is upper in the upper abruptio, but PV is usually not done unless you have a dual setting in which if the patient bleeds on the table, you can start with cesarean right away. Next slide, please. So the complications that we generally face in these patients of abruptio are maternal and fetal. In maternal, there's a hemorrhage. There may be which may be even intraperitoneal, or there may be a broad ligament hematoma also. Shock due to bleeding, and thromboplastin into the circulation it enters, or there may be amniotic fluid embolism, which leads to shock. Coagulation disorders, as we've already seen, and oliguria due to hypovolemia and release of serotonin from the damaged uterine muscles, leading to renal ischemia. There may be acute tubular necrosis because of that, and in severe cases, it may lead to even anuria and cortical necrosis and renal failure. PPH due to atony and high FDP products. Maternal mortality is usually 2 to 8% due to shock, coagulation defects, and renal failure. And if the patient survives at all in the long term, some patients may even go into Sheehan syndrome because of the pituitary ischemia that has taken so long. Now, fetal conditions, they may be IUGR, hypoxia, preterm birth, and stillbirth, especially in the concealed hemorrhage, it is by 50 to 100%, and in reveal, it is in the order of 25 to 30%. In abruptio, the complications are far more than in the placenta previa because of pre-existing placental pathology with a poor placental reserve. Recurrence in subsequent pregnancy is 10-fold higher, and the perinatal mortality is no less than 10%. Next slide, please. So to manage, what are the things that we consider? It depends on the period of gestation first, the amount of bleeding that has occurred, and the presence of complications like shock, DIC, or hypofibrinogenemia along with the abruption. By hypofibrinogenemia, when the fibrinogen is less than 150 milligrams per deciliter, there is raised FDP and D dimer type and grade of the placental abruption. Malpresentations, whether the patient is a case of previous cesarean section, whether she has fetal distress, or the baby is congenitally malformed. When a patient in late pregnancy with bleed PV comes, evaluation and treatment start hand in hand. Hence, it is a teamwork, and at the same time, the attendants should be regularly appraised of the grave situation of both the mother and the fetus. Need for ICU facilities, NICU, blood and blood products availability, and the need for hysterectomy if the situation demands. The physician and anesthetist should be available to manage renal failure, and if the baby is already dead in utero, that too should be conveyed to the attendants immediately, or else they may say, because of lack of treatment, you are responsible for it. CVP is the best guide to monitor the patient. It should be at 10 centimeters of water, as the peripheral blood vessels are in spasm then, and a target of hematocrit at 30% and urine output at 30 ml per hour should be kept. Correct the hypovolemia, send investigations like CBC, KFT, APTT, PT, and fibrinogen, D dimers, and if thromboelastography is available, well, that will help a lot in the management because it tells you whether you need fibrinogen, you need platelets, and how much of PRBC. Now, to infuse the fluids, you have to have two thick bore needles, and don't use the pink ones, which are generally used for the pediatric cases. Request for blood products as per need. Check for fetal condition, whether the patient or baby is in distress or it's already an IUD, if there's a malpresentation or not, and an ultrasonography for confirmation of the diagnosis. Whether the patient is in labor will also determine the treatment as well as the CTG findings. Next slide, please. The expectant management is only done when the BP is stable and the hemoglobin is more than 10 gram%, hematocrit more than 30%, the period of gestation more than 37 weeks, and the fetal condition is assured, and there's no active vaginal bleeding. Bleed USG, when the USG is normal, betamethasone is to be given if the baby is preterm. Strict continuous monitoring of the patient and the fetus is required. Expectant treatment is an exception in abruption as compared to other cases. Amniotomy acts by stimulating the uterine contractions. Compression of the spiral vessels reduces bleeding and reduces the entry of thromboplastin into the circulation, thereby reducing DIC and thereby reducing the cortical necrosis. The aim of treatment is to avoid shock, coagulopathy, renal complications, and provide a viable baby without jeopardizing the mother. Next slide, please. So for vaginal delivery, we do a low rupture of the membranes and oxytocin drip is started, and you continue the CTG monitoring of the baby's life. Indications for vaginal delivery are if there's a mild bleed, the FHR is normal, favorable cervix is there, and the CTG available is reassuring, or it may be case of IUD. The indications for preterm delivery are there are recurrent bouts of bleeding, or the patient is a case of IUD, and the baby has congenital malformations. Indications for cesarean, the bleed occurs after 37 weeks of pregnancy and the patient is in labor or the patient is exsanguinated. There is already an IUD and she's bleeding profusely. Hypertension is rising despite treatment. Amniotomy failed to control the bleeding and the Bishop score is poor, or the patient has severe oliguria and the fibrinogen level is falling. If the patient is Rh negative, anti-D gamma globulin has to be given, and of course the dose has to be given according to the bleed, because if you give the standard 300 micrograms, it may not suffice, and despite you giving the dose, the patient may land up with sensitization. The PV is contraindicated when the patient is already severely exsanguinated, or she has a malpresentation, you have to do a cesarean, or the patient is a case of previous cesarean for a recurrent indication. Now, anesthesia, generally, it is not the regional type because it may worsen the hypotension, and supine hypotension, of course, has to be avoided. Next slide, please. So management of the complications also has to go on side by side. That is, if the patient is in shock, immediately arrange to manage the shock. Central venous lines may be needed. DIC, you have to provide fibrinogen or and the cryoprecipitate or platelet count as needed. And the renal failure, of course, has to be managed on a war footing, because once it settles, and the time is a very important factor in preventing the necrosis, cortical necrosis. Now, uterine atony, if it is there, and that may lead to PPH, the fibrinogen has to be brought to more than 150 milligrams per deciliter. 1 unit of blood contains 0.5 milligrams per ml of fibrinogen and increases its level by 12.5 milligrams per deciliter. Platelets are raised by 10,000 to 15,000 kVs per ml. Next slide, please. So the differential diagnosis, we've already talked about it. They're in the revealed type from placenta previa, concealed type from indeterminate hemorrhage, and also from rupture of the uterus, rectus sheath hematoma, appendicular or intestinal perforation, twisted ovarian tumor, and volvulus, acute hydramnios, and tonically contracted uterus. In USG, it may be confused with the thick placenta or fibroid, and the points to support the diagnosis of abruptio are shock out of proportion to the bleed, height of the uterus not corresponding to the period of gestation, PET may be present, coagulation is deranged, oliguria is there, and if the uterus is very hard. Next slide, please. So prevention is by preventing the risk factors like treatment of hypertension early, preventing eclampsia, HELP, and avoiding smoking, and avoid sudden decompression. Amniocentesis always under a USG guidance, and folic acid administration. The prognosis depends on the period of gestation, the grade of the abruption, and the presence of complications. Long-term effects are cerebral palsy and developmental disorders. The survival rate, the perinatal death rate is usually 7.9% in the term babies, 5.8% in moderate, that is around 34 weeks, and preterm deliveries, 11.1%. Thank you all so much for lending me a ear so patiently. Thank you so much.
Dr. Kumudni.
Thank you, Kumudni.
Everything.
Was such a, just a minute. Thank you, Kumudi, for such a fabulous presentation. You've left no stone unturned, as expected of you. And I think all
Thank
of
you
us
so much for that compliment.
you were an inspiration for us when we were juniors.
But now
Thanks
you
for
all
your
are
presentation. Huh?
You all are the same now, all colleagues.
No, we are
questions.
at that time we used to look at you and we used to follow you.
Thank you so
Thanks
much.
for
Questions
that.
allowed?
You've come up. Thank you.
Ramadi sir, please, your comments, please.
Yes, yes. I think 1 to 2 questions should be asked. On ultrasonogram, there is one Gilles sign. What is that Gilles sign?
I'm not sure about that, sir.
Gilles sign, G-E-L-L-E sign. Because when you put the transducer, there is a jiggling of the clot, blood clots. So this is known as the Gilles sign. There is one comment on it. And I think there should be 8 questions that should be asked about this from the patient. When you suspect the abruptio, is the mother hemodynamically stable? Is the fetus alive? What is the gestational age? Does the fetus need to be delivered immediately? Is the fetus heart abnormal? Is the patient is in labor? What is the cervical status? And is there is coagulopathy? When the answer from this 8 questions will be there, then the management depends upon all these things. I think, again, I thank Dr. Kumudni for a nice presentation. Thank you.
Thank you, sir, and Kumudni madam for your extensive presentation. And now we will move on to the second session, where the speaker is none other than Dr. Pratibha Singh, a very good friend of mine, and this Dr. Maya Sankar Thakur, Dr. Rekha, and Dr. Prachi Singh. May I have their CVs, please? Regarding Dr. Maya Sankar Thakur, he's a very senior person and he's secretary Darbhanga OB-GYN Society. Sir, welcome you, sir. The next CV. This is CV of my friend, Dr. Rekha Jha. We have already seen her just 2 or 3 days back. Her dynamic work shown in AOGS BJ conference, annual conference. She is President Bhagalpur Obstetric and Gynec Society, Region Coordinator of Public Awareness Committee, FOXY, past Vice President of IMA Bhagalpur, past RCH Coordinator, and a lot of work, social work she has done, life member of Menopause Society, life member of Red Cross, worked in various capacities with many NGOs, Rotary Alliance, Jeevan Jagriti, anti-corruption.
Suman, you are muted now.
No, who muted me?
I don't know.
By default. So, could anyone hear or I have to repeat?
No, it's not necessary to repeat.
No, just a minute. I mean, I have to do it.
I would just say
you were involved in various capacities with many NGOs.
So I would
almost done. So, Dr. Rekha, after that, the next one. Can I have the next CV? Dr. Prachi, yeah. Another friend of mine, a very young friend of mine, Dr. Prachi. She is from Ashirwad IVF Center, Muzaffarpur. And she's a lot of work doing in infertility. She's also E-Zone Coordinator, Imaging Science Committee, FOXY, Founder Secretary of ISOPA, Muzaffarpur, Joint Secretary, MOX, Secretary IMA, Muzaffarpur, 2019. Yeah, I've already said she's first IVF center. She has first IVF center of North Bihar. Congratulations. A recipient of Young Gynecological Award, first conference of AOGS BJ, and many publications in FOXY, manual imaging in obstetric and gynecology journals. Welcome, Prachi.
Thank you, madam.
I request Dr. Maya Sankar Thakur sir to introduce our speaker, Dr. Pratibha Singh. Is sir there?
Think is.
So Rekha, please introduce.
I'll do that because I have to catch a train. So
where are you going by?
I have to go to Kolkata.
Okay.
Anyway, Professor Dr. Pratibha Singh, she's from our own society, Bhagalpur Obs-Gynae Society, but she has a lot of accolades to her name. Consultant laparoscopic gynecologist and IVF specialist, director at her own Healing Touch Multi-Speciality Hospital, national coordinator for IAEC FOGC, chairperson-elect IAEC FOGC in 23-25, president Bhagalpur Menopause Society, and diploma in advanced gynec laparoscopy.
Thank you, Rekha madam. I think everybody knows me. I think we should start.
I know, but so you can start with your talk, and I think it is about adherent placenta. We would like and love to hear that. Okay, so Pratibha, you can start your presentation.
Can you see my slides?
Yes.
Hello?
Yes, it has started.
It's full screen?
Yeah, make it full screen. No, it's not full screen.
It's not full screen.
No.
Now it is full screen?
No.
Eh?
No, not yet. Double click.
Is it full screen now?
No, now we can't see.
Oh. Just one.
Yeah.
Madam, can you show your screen? Then I'll tell you how to make it full screen.
He already knows, but there is some problem with the computer.
It is not loading actually.
Can you share to Basist? He can do for us.
No, just a minute.
Actually, she has to do it by herself because I don't have any rights for her device. No?
That I know. If he shares you on your mail, then he can do it, or in my mail.
Yes, that I can do. No?
That sometimes there is not a problem with it.
Otherwise, ma'am can go with the normal presentation only, ma'am.
Yeah.
Yeah,
it's okay. It's okay, Pratibha. Go ahead.
This is not full screen.
No, not yet. It was, then again. Can we do anything to this? We can't do.
But I can.
But ma'am, still it is visible.
But it is visible, Pratibha.
It is visible,
you can
clearly visible, ma'am.
You can go on.
So, good evening, everyone, respected chairpersons and my dear friends. A very good evening to all of you. First of all, I would like to thank the organizers, especially Dr. MC Patel sir, for giving me this opportunity. And my regards to Dr. Rangila Sinha madam, Dr. Anita Singh madam, Dr. Beena Sinha, and all the colleagues who have joined today, Dr. Sneha, and all seniors who are present today. So, with this, I also want to thank all those who joined Bhagalpur for this 9th AOG SBJ conference. So thank you so much for visiting Bhagalpur and sparing your valuable time. And it was a great fellowship and academic we shared here. So thank you so much. And now with this, I will be starting my talk. Just now we heard a very informative talk on a very dreaded obstetric complication by Kumudni madam. And now I am here to talk on another very difficult obstetric complication, which is again a nightmare for any obstetrician, that is placenta accreta syndrome disorder. Now, placenta accreta spectrum disorder, or Abnormally invasive placenta is a clinical situation where placenta does not detach
Ma'am, actually
spontaneously.
slides are not moving, ma'am.
It's not moving.
Ma'am, actually you need to exit full screen and then you can move it.
Okay.
Just don't click on full screen.
Now can you see?
We can see, but move your slide.
Ma'am, can you just move your slide?
Now you can see.
No.
Ma'am,
your
slides are not moving.
Shown.
Your
CV
slides are not
showing,
moving.
Pratibha Di, only CV is being shown.
What has happened? Now it is moving.
No, it's not moving.
No, ma'am, it's not.
Huh? Just
so I think can we move on to the third session and then again Pratibha, you can share with Basist and he will do for you.
Ma'am, I have shared my mail ID in the chat box, ma'am.
Okay, that will be better, I think. Just let her try for a few more minutes.
Just a minute. Once more, I'll try if it is open.
You take your time and then we move on to the third session.
Now it is moving?
No, ma'am.
No.
It is disabled actually. It is showing disabled.
Is the connections okay? Connections okay?
Yeah, everything is okay because it is showing that it is disabled.
So you have only one option. Send it to Basist mail and then he will show for you. And by the time we can go move on to the third session.
देखो तो विवेक फिर क्या हो गया इसको स्क्रीन नहीं आ रहा है जा तो देखो तो हाँ
Dr. Apurva, are you there?
Yes, ma'am.
You take up the third session. Please introduce our chairperson.
Yes, ma'am.
Yeah, thank you.
Yes, ma'am. I'm here. I am here.
Can you introduce our chairpersons? Or should I do for you?
Yes, ma'am. Yes, ma'am. Just no, ma'am. Just 1 minute, ma'am. Yeah. Actually, I just stuck in some emergency cases. Yeah. Actually, the screen is not visible.
To you?
So, am I audible, ma'am?
Yeah, you are audible and visible also to us.
Yeah. So, respected seniors and dear friends, now it's I think most exciting topic now, which is taken by our respected Dr. MC Patel, sir, that the legal issue in the placental abnormalities. So, for chairing the session, we have a very three eminent gynecologist, Dr. Kavita Varnamal, ma'am, and Dr. Prabhati Kesri, ma'am, and Dr. Lata Shukla Dwivedi, ma'am. So, doesn't need any introduction. Dr. Kavita Varnamal, ma'am, is the senior consultant laparoscopic surgeon and at present the secretary of the Bhagalpur Ojhavi Society. Dr. Prabhati Kesri, ma'am, is the Dr. Prabhati Kesri, ma'am, is the immediate past secretary of the Bhagalpur Ojhavi Society. She is at present working as a medical officer ART Center at the Medical College, Bhagalpur. Dr. Lata Shukla, Madam, is the professor and HOD Obs and Gynae at the Magad Medical College. So thank you so much, respected seniors, and agree to be the chairperson of this very wonderful and interesting session. So I would like to first take a note from Prabhati ma'am, introduction of the subject, and then Dr. Kavita Vanwal ma'am will introduce our speaker, Dr. MC Patel sir. Prabhati ma'am.
You are unmuted, Prabhati. Unmute yourself.
Good evening to all and one. It's a proud privilege today to share this session of great Dr. MC Patel sir, who is the organizing person of this webinar and this series of webinars which is doing Happy Learning. The legal issues which has to be faced and that has to be documented will be taken up by Dr. MC Patel sir, and let's not waste our time and move on to the next chair person so that she can introduce our speaker, Dr. MC Patel sir. Over to Kavita ma'am.
Thank you so much, Prabhati ma'am. Yeah, Kavita ma'am, over to you.
Yeah, thank you. Thank you, everyone. Thank you, Patel sir, for giving me an opportunity to introduce you. So just like showing a diya in front of sun. So he is so popular and he has really united the whole country from north to south and from east to west by Happy Learning classes. So really, I think he has already been introduced, but just I am requesting him to give this important sessions, which is very important for all of us.
It will
so
do. Yes,
I request sir, yeah, to start the topic.
So let me share my screen. Is it seen?
Yes.
Yes.
Yes, sir.
And is it in full screen?
No, sir.
No, sir.
Yes, no, in full screen?
Yeah, now it's full screen.
Now it is full screen. Yes, sir. Yes, sir.
Because in my computer it is in full screen.
Now it is
It is visible.
Sir, now
It is in full screen only, sir.
Okay, so it is full screen.
You can go ahead, sir.
Okay. So greetings from Statue of Unity, tallest statue of world, and we all are proud of that statue. So I invite you all for 45th SOGOK conference, that is State Conference of Gujarat, on 9th, 10th and 11th December at Statue of Unity. Of course, it is hosted by Ahmedabad Ubijayan Society, but it is destination conference at Statue of Unity. So I invite you all to be part of that conference. So medical legal issues related to placental abnormality. Let us see which kind of problems we may encounter as far as placental abnormality management is concerned. So warm welcome all the delegates and wishing you a litigation-free practice. At the outset, I would like to thank all the 4 societies of Bihar, all the presidents and secretary of respective society, that is Muzaffarpur, Bhagalpur, Gaya, and Darbhanga, and all the delegates who have joined this webinar. Usually I start any of my talk with this question: is it worth discussing? Yes, and if it is yes, then why? Because medical litigations are increasing in number constantly and steadily, and unlucky, we gynecologists friend rank first, because in our day-to-day obstetric practice, we take utmost care of any of our patients, but accident may happen at any time and we may be held up into litigation. Let us see, these are the real cases happen in Gujarat only. It was unbooked patient, primary 34 weeks pregnancy, PIH, advised necessary investigation and treatment. This was the very first visit of this patient to that gynecologist. Previously, she was at her in-law's place. She was consulting some other gynecologist. Now she had been to her maternal place, and with this gynecologist, it was very first visit. So he advised all necessary investigation and treatment for PIH. But unlucky on part of patient as well as that gynecologist, very next day, she developed abruptio placentae and intrauterine fetal death. Cesarean section was advised. Relative option to go for second opinion in nearby town. So patient was brought to a surgeon in nearby town, and cesarean section was done. Again, unlucky on part of patient and that surgeon also. She developed atonic PPH and hysterectomy was done. You imagine primary patient, intrauterine fetal death and hysterectomy. And notice was served. So to first gynecologist, not properly managed to prevent abruptio placenta was the allegation. And allegation to surgeon not tried to prevent PPH and atonic PPH was not managed properly. I was counsel for both of them in court of law in the CPA. Of course, we won the case, but this type of cases are very much common because whenever something goes wrong, then there are potential situations for litigation. Let us see one more case. Of course, it was not a medical legal case, but it was my personal experience. Again, it was unbooked patient. This patient was delivered at Rajasthan and adherent placenta was left in situ. Abdomen was closed after cesarean section and adherent placenta was left in situ. No active bleeding per vagina. Vitals were within normal limit. Patient was referred from Rajasthan to multi-speciality hospital at Ahmedabad. After a few days, patient was discharged against medical advice because in multi-speciality hospital, there was tremendous expense and patient had no much money to spare. So patient was shifted from that multi-speciality hospital to private surgical nursing home and that surgeon called me for opinion and further treatment plan. But lucky on part of patient, her vitals were normal. There was no active bleeding in this particular case. Patient and her husband were very keen to remove uterus with placenta in situ. They were not at all interested to go for any kind of conservative treatment and they were very interested to go for hysterectomy. We counsel patient well in details, including role of urologist and necessity of blood or blood product transfusion. And she was very much happy with our counseling because we explain her that it is all likely that bladder may get injury because it was case of percreta and bladder was already involved. So she was counseled well. She was investigated preoperatively and surgery was planned. Urologist assisted me and post-operative period was uneven. During surgery, we both were of opinion to open bladder first and then to manage because it was percreta and we were interested to know how much placenta is going in bladder. And we could successfully remove uterus and we repair bladder also. Post-operative period was uneventful. Patient was discharged in due course with urinary catheter in situ. Follow-up examination was also normal. So in this type of situation, we were lucky that patient was knowing that placenta is in situ due to adherent placenta. Patient was keen for hysterectomy and we could manage case nicely. But many a times it may happen that all the reports you get normal and during delivery or on table during cesarean section, you come to know that there is adherent placenta or placenta previa and it becomes little difficult to explain patient or convince rather patient and relative. So not to end up into this type of problem, whenever you advise any sonography in your book patient, there are three possibilities. Either they will insist to get sonography done by you only, or you will by her own. So if patient has preferred, it's fine. If it comes with normal report and placenta previa or adherent placenta comes, it becomes little easier for us. But when we have done or we have referred patient to sonologist and with normal repeat, when we come across placenta, difficult one. So in all this situation, proper counseling and proper consent is very much required. So in this particular case, patient was very happy. So as far as placenta is concerned, we know it is crucial feto-maternal organ with both embryonic, that is chorion throndogen, and maternal, that is decidua basalis components. And placenta has numerous and complex developmentally essential functions such as nutrition, excretion, and immunological and endocrine function. So if you go with this chart, it is a good barrier, and placenta guards the fetus, grants nutrients, exchange of gases, metabolites, hormones, and governs homeostasis. So to achieve this goal, placenta adopts various positions, changes in its dimension, size, thickness, and depth of penetration. So it is a physiological process in so many of the cases. And which are the placental abnormality we are facing in our day-to-day practice? Either it is structural abnormality or functional disorders or site of implantation abnormality. And when we come across any of this condition, our role to counsel patient and patient party well is the crucial point. So abnormal implantation, it could be accreta, increta, percreta, morbidly adherent placenta, or abnormal invasive placenta. It could be placenta previa, it could be vasa previa, and placenta variants. Bilobe placenta, not increased risk in many of the cases. Multilobe placenta, velamentous insertion of cord, circumvallate placenta, placenta membranacea, and succinate placenta. So these are some abnormality we may face in our practice. Chorion intervillositis, placental mesenchymal dysplasia, diabetic placenta. In GDM also, we come across diabetic placenta also. Placental chorioangioma, placental infections, placental membranes, chorion amnionitis, and gestational trophoblastic disease in few of the cases, that is hereditary mole or chorion carcinoma. So whenever we are dealing with this situation, we should be vigilant to deal with the patient, because all these conditions are potential situation to face litigation in court of law. But major point in issue in our obstetric practice as far as placental abnormalities are concerned, first is hemorrhage, second is infection, it could be abortion, preterm labor, IUGR, morbidity, and in few of the cases, if not properly managed in time, then mortality also. And as far as adherent placenta is concerned, if not diagnosed before, just I mentioned prior also, can lead to catastrophic postpartum hemorrhage with life-threatening complications. And as far as vasa previa is concerned, pathologic structure can cause fetal blood loss with significant neonatal morbidity or death in case of spontaneous rupture of membrane or amniotomy. Let us see. This case was shared by one of our Foxian friends from Maharashtra, Dr. Pallavi Ingle. It was G2P1L1, previous LSCS, non-diabetic, normotensive, no risk factor, came with loss of fetal movements at 36 weeks of pregnancy, sonography, transverse lie, corresponding fetal age, normal Likert, Doppler normal. The only positive finding after cesarean section was grossly twisted ovarian, twisted umbilical cord, and no true note, and one loop. It was of course loose of cord around neck. And is it possible that twisted umbilical cord is the reason for sudden IUFD at 36 week of the pregnancy? So it is interesting case. So it is normal umbilical cord, but that very particular case which Dr. Pallavi said, and with this photograph of twisted umbilical cord. So in this type of situation, of course, it is accidental finding once, and before that, it is very difficult to diagnose this type of situation. So twisting of umbilical cord leads to obstruction in flow of blood in umbilical cord vessels, leading to acute placental insufficiency and sudden fetal death. So which are the areas for litigation related to placental abnormality? You may end up into litigation in this type of the situation. Delayed in diagnosis, investigation or treatment, misdiagnosis, investigation or treatment, wrong diagnosis, unnecessary investigation could be one of the allegations, because to come to correct diagnosis, we have to subject patient for many investigation, and many times this could be one more allegation. no proper consent was taken could be one more allegation. Staff not qualified, infrastructure issued, emergency services not rendered properly could be one more allegation. Communication failure, if patient and patient relatives are not communicated well, then it could be one more allegation. Delayed in transfer, many times we have to delay patient to higher center, and if it is delayed, then it could be one more allegation. Complications related to all this placental abnormality just we mentioned prior, morbidity, maternal and or fetal, and in few of the cases mortality, maternal and or fetal could be the area for litigation. Overcharging, because in this type of cases, it is all likely that expense will be much higher, and tremendous expense against an unexpected result could be one more area for litigation. One more area, ask for medical records, and if you have not provided, and failure of patient to comply with schedule follow. But in this type of situation, whenever you have advised patient for schedule follow-up, and if patient doesn't come for follow-up regularly, or if she is irregular, then it becomes a contributory negligence on part of patient, and it becomes a good defense in court of law in your favor. But in this type of situation, you will have to prove that patient was not complying as far as follow-up treatments are concerned. So most common allegation, just I mentioned, not anticipated and not prepared to manage. So whenever you are facing this type of litigation in court of law, first question usually comes from prosecution: was it preventable? Was it preventable? Not to anticipate or not to prepare to manage? And if it is yes, then what did you do to prevent it? And why you couldn't prevent it? In spite of all your care and caution, if you couldn't prevent it, then one more allegation will be there. And did you diagnose that complication very much in time? And one more question: did you manage way in which any prudent doctor would have managed? So if you can answer all those questions related to placental abnormality, then you could be out of problem. One more area, delayed in diagnosis. All those questions you will have to face. Recurrence. It is also, we know, as far as placenta previa is concerned, recurrence is very known. So in this type of situation, very common allegation is no proper care taken to avoid reoccurrence. So in case of placenta previa, we know that recurrence is known. So it should be well counseled to the patient that it could be reoccurrence at any time, and we should be mentally prepared to face the situation. So again, in recurrence, all those questions we will have to face. Missing diagnosis, again, all those questions we will have to face. So what to do and how to prevent not to end up into litigation? Foreseeability or anticipation. So court and law expect from you foreseeability or anticipation about probable complication, and you should be readily available to deal with situation properly with all intensive care, and possibility of blood transfusion in this type of situation should also anticipate, and we should be readily available to deal with the situation. So as far as anticipation is concerned, say for example, if you are dealing with a case of previous to LSCS with central placenta previa, then naturally you should anticipate PPH, possibility of blood transfusion, and in few cases obstetric hysterectomy also. So in this type of situation, you should counsel patient well. So proper counseling is very much required. More is the time you spend with the patient in consulting room, less is the possibility of you needing to spend time with that patient and relative in court room. So communication is key to avoid litigation, and it is very obvious that we might have the best medicine in the world, but it won't be successful if patient doesn't understand it. And as far as our counseling is concerned, in our consulting room, usually we start like this: what is the complaint? And there could be so many questions on part of patient. Why did it happen? How it can be avoided? Will it happen again? Could it have been avoided? So at the time of counseling, we are under obligation to advise or counsel patient all the alternative modalities of treatment, possibility of morbidity, probable expense, possibility of mortality in few of the cases, probable prognosis, probable complications, possibility of blood transfusions, risk involved, and outcome of baby should also be counseled. And need of PCU should also be counseled to the patient. But all whatever we counsel, it should be in a very simple language, no much medical jargon, and it should be in a simple language which patient can understand, and no rosy picture, no tall claim about result. Because in this type of situation, whether it is adherent placenta, whether it is abruptio, whether it is previa, we know our result, ultimate result in obstetric practice. Many times we may consider like Aishwarya Rai, but it may turn like this at any time. So no tall claim, no rosy picture, because in eye of law, when you claim to be master, you are supposed to be master. So proper communication is key to success. And when you take signature on a consent paper, then it becomes a documentation of your communication. In this famous case of C. Jaipal Reddy versus Padmini Veluri, National Commission has very specifically mentioned that consent is not mere piece of paper where patient or relative has to sign, but an important document of your counseling. Whatever you have counseled to the patient, all these points should be entered into consent paper, and then patient and patient party should sign. So it is a documentation of communication, and communication of documentation. When you offer all those records in court of law, it becomes a communication of your document. And just mentioned prior also by one of the faculty, now on Foxy website, almost 30 different consents are available. We three medical legal experts, Dr. Dilip Walke from Pune, Dr. Nikhil Datar from Mumbai, and myself, Dr. MC Patel from Ahmedabad, we have prepared almost 30 different consents. Say, for example, cesarean section, abdominal hysterectomy, vaginal hysterectomy, endoscopic hysterectomy, the referring patient to higher center in critical condition. This time, HSG, medical termination of pregnancy by medical, by surgical method, blood transfusion, anesthesia consent. So you have to simply visit Foxy website, and you can download and you can utilize in your day-to-day practice. So at the time of preparing this consent, we have taken based on famous case of Samira Kohli versus Prabha Manchanda, which was decided in 2018 Supreme Court. So taking this base, and we had a collaboration with Law Society of Maharashtra, and many a times on web, for one word or one line, we had a ample discussion for hours together, and then only we have come up with all this those consent. But still we are open. If at all any suggestion as far as those consent are concerned, then I am and all my colleagues who have prepared this, we are open to discuss and to edit also. But in all this situation, records are always at rescue. So keep them up to date. What was done, nothing was neglected, and given treatment fully met with standard demanded by law and ethics. So in given situation, how you manage the case is also considered in court of law. Many times ultimate result is not considered, but how you have managed the case, because we will see in few of the cases decided in Supreme Court just now. So it should be easily acceptable whenever offered by the a person in the court, because doctor is bound to produce record whenever asked by the court, and if he doesn't, then adverse inference might be drawn, and it is very obvious. Good record is good defense, poor record is poor defense, and no record is no defense. And it has been my experience during my medical legal practice. We doctors' friends are very poor as far as record keeping is concerned. So let us see, in this case in Supreme Court, Apex Court has observed as follows. The skill of medical practitioner differs from doctor to doctor. There may be more than one course of treatment which may be advisable for treating person, because many a times we have more than one option for treatment. So merely on ground, we have accepted to go with one option of treatment, and why you didn't select that other option cannot be the ground for litigation. So there may be more than one course of treatment which may be advisable for treating a patient. And very nicely Supreme Court has mentioned that courts would indeed be slow in attributing negligence on part of doctor if he has performed his duty to the best of his ability and with due care and caution. Again, in famous case of Jacob Matthews versus State of Punjab, the same Supreme Court Justice Lahoti, they had also mentioned that doctors should have taken reasonable care, not extraordinary care. They have mentioned reasonable care, and he should have exercised ordinary skill. So court doesn't expect from us extraordinary skill and extraordinary care. But if you have done your duty with ordinary skill and with reasonable care, which any other prudent gynecologist would do, you are out of problem. So these are some good judgments. Let us see in this particular case, court further added that medical opinion may differ with regard to course of action to be taken by doctor treating a patient, but as long as a doctor acts in a manner which is acceptable to the medical profession and court finds that he has attended on the patient with due care, skill and diligence, and if patient still doesn't survive or suffers a permanent ailment, it would be difficult to hold doctor to be guilty of negligence. So in this case, Supreme Court has very specifically observed and inference held by the court. In one more case, again apex court, that is Supreme Court, while dismissing the complaint was on part of patient, and in this case decided in favor of our gynecologist friend. Consumer Protection Act should not be halter around the neck of doctor to make them fearful and apprehensive of taking professional decision at crucial moments to explore possibility of reviving patient hanging between life and death. So it was very specifically mentioned by Supreme Court. When you are dealing with a dire emergency, naturally you are going to offer your best possible diligence and care. But if at all something goes wrong, then this cannot be the ground for litigation. Doctors in complicated cases have to take chance, even if rate of survival is low. And doctor faced with an emergency ordinarily tries his best to redeem the patient out of this suffering. So we have many this type of judgment in our favor as far as litigation part is concerned. This gentleman have so many staircases, but he doesn't know how to use them. So it doesn't matter how many resources you have. If you do not know how to use them, they will never be enough. So just I mentioned, there are so many judgments in so many courts in favor of doctor, but if you do not know, then it will be useless. So have some basic legal knowledge. Always obtain medical legal advice. Doubt. There is always a way. So to conclude, my talk not to end up into litigation as far as placental abnormalities are concerned. Proper antenatal and labor ward protocols is to be strictly followed. Adequate supervision and monitoring during labor and during
antenatal labor
proper
ward
communication, counseling, and proper consent, documentation and record keeping, foreseeability and anticipation, and we should be readily available to deal with the situation. Help from professional colleague. So multi-speciality approach. In this type of situation, whenever you are dealing with any placental abnormality, and if you have availed services from your professional colleague, it shows your concern to manage a situation very effectively, and it shows your concern to save life of patient. So do not hesitate to take services from our professional colleague. And of course, in era of this CPA, proper indemnity cover should be there, and audit of our own case where things went wrong, and not to end up into this type of problem in future. So medical audit in our own case is also very much required in this scientific era. So in spite of all this care and caution, a professional hazard and occupational hazard are there. So in spite of all these occupational and professional hazards, our journey to serve human and mankind is always on and on. So if you want to sleep like this, take tender care of your patient, comply with the protocols as far as treatment part is concerned, pray our Almighty God before going to sleep, and keep my visiting card below your pillow. And this is law of leopard behind innocent gynecologist, and see the role of medical legal counselor in any given situation. So please do not hesitate to avail opinion or services from medical legal counselor in any given situation. So सत्य परेशान हो सकता है लेकिन पराजित नहीं. With regards, with salute to all the societies who have joined this webinar, and wishing you a litigation-free practice. Thank you very much. Please do not assume. Please ask if at all any query, if time and chairpersons permit. Thank you very much.
Thank you so much, sir. It's always really a wonderful and eye-opener for all of us after listening to your lectures. And definitely placenta is one of the very, tricky things to deal with. So thank you so much, sir, for this. I would like to invite the chairperson, Dr. Lata Shukla ma'am, your comment, please. Dr. Lata ma'am.
Thank you. Can you hear me?
Yes, ma'am. You are audible.
Thank you very much, sir, for your informative and excellent presentation. And also thanks for giving me this opportunity to share this session. And I think complication will occur, but we have to expect the complication and proper counseling and proper consent from the patient. That will prevent us from medical legal, and proper communication with the patient and diagnosis, and no rosy pictures, as sir said, Aishwarya Rai and that lion. So rosy picture should never be presented to the patient. And sir said the consent, documentation of the consent, and communication of the documentation. And one important thing is record keeping and up to date record keeping. And best the sir has presented so many cases of Supreme Court and the case report and all. The best of all has come with opinion that best of our ability, if we do something that is considered. So thank you again, sir, very much for this medical legal aspect. Thank you, sir.
Thank you very much, madam.
Thank you, sir. It was really eye-opening session, and we could learn and how to prevent the litigation that is used to be done with our cases and with us. So thank you, sir. So we like to hear more and more from you after this also. So thank you so much and wish you all the best. Thank you, sir.
Thank you, MC Patel, sir. It was an excellent talk, and it is always an eye-opener speech whenever you give us the advices how to keep us safe and the patient safe. Thank you very much, sir.
And one thing more I want to say, sir is cordially invited at Gaya, Magad Dogs and Gynae Society.
My pleasure, madam.
Okay, thank you, sir. And I must also thank my senior colleagues and teacher, Madam Rangila Sinha, Dr. Ramadhar Tiwari, Dr. Anita Madam, Dr. Patel sir, and a special thanks to Dr. Suman Sinha, Pratibha, Kavita, and Kumudni Jha Madam for very much informative and coordinating activity in this program. Thank you, sir.
Thank you so much, chairpersons. And thank you so much, our respected MC Patel, sir, for a wonderful lecture. So moving to the second lecture, over to you, Pratibha ma'am.
Can you see my slide now? Hello?
Yes, ma'am. Yes, ma'am.
It is moving? It is moving?
No, ma'am, please, aap move karo.
Pratibha Singh, madam, make it full screen.
Make it full screen and then try to move, ma'am.
But it is not moving.
No.
No,
ma'am.
It is not full screen. So make it full screen first.
And then it will move, I think.
Yeah, I'm making.
मैम आप स्लाइड मूव करो. दिख रही है मैम, आप स्लाइड मूव करो.
स्लाइड तो दिख रही है, मूव नहीं हो पा रहा है ना, तो फुल स्क्रीन भी शायद नहीं हो पा रहा.
Then second option is with cursor.
Omkar,
with cursor.
I think you need to share the screen.
No issue. I will share this.
Can you see now?
Okay.
Can you see now?
No, the
Yes,
problem
ma'am. Now
is
it's moving.
It's moving.
Now it's moving.
Bingo.
So I'll do with this only. Okay.
Yeah, it's moving now. Now moving.
Okay. So,
but it is not
sorry
the full
for
screen.
this problem, and I'll be talking on placenta acreta syndrome disorder. Can you see now? It is moving now?
Yes, ma'am.
Can you make it full screen, Pratibha?
It cannot be. I am not able to make it full screen actually.
Okay.
So placenta accreta spectrum disorder or the abnormal invasive placenta is a clinical situation where placenta does not detach spontaneously after delivery and cannot be forcefully removed without causing massive and potentially life-threatening bleeding. And the incidence of this placenta accreta spectrum, which we call it PAS, is rising worldwide, and it is mainly because of the increasing rate of cesarean deliveries, which is the major risk factor for PAS in subsequent pregnancies. And this is also associated with maternal morbidity and mortality, which we all know because we are forcefully removing placenta and trying to detach placenta from uterine cavity. And when it is adherent, it causes massive and torrential bleeding, which may be life-threatening for the patient. So in such cases, whenever you are dealing any of the previous section patient, if you are taking her for the second section, you must always have suspicion that there may be a chance of any adherent placenta, and for that you must diagnose it before delivery. And once you have diagnosed, then such women should be managed by a multidisciplinary team with expertise in this condition, and that will reduce maternal and neonatal outcome and will improve their conditions. So that is very important. Now, we all know that in normal placenta, the normal placental, it has an intact decidual basalis. But if the placenta becomes abnormal, or when there is abnormally adherent placenta, in that case, there is a defect in the decidual basalis. And usually what happens, in accreta, the endometrium is defective, so it gets adherent to the endometrium. And in increta, this get invaded into the myometrium, but it gets adherent. And in percreta, it gets invaded into the parametrium or reaches up to the serosa of the uterine cavity. So it is mainly because of the defect in the decidua basalis. Now, initially, the terminology of morbid adherent placenta is now being changed to PAS, that is placenta accreta syndrome, and which include both abnormally adherent placenta, that is placenta accreta, along with abnormally invasive placenta. So it includes both placenta accreta, increta, and percreta. And even FIGO defines it as grade 1, grade 2, and grade 3 for this. Now, what are the pathophysiological changes which occur in this? We all know it is mainly because of the partial or total absence of decidua basalis and defective development of the fibrinoid, which result into the abnormality in the firm adherence. And also there is a defect in the biological functions of the trophoblast, leading to the excessive invasion of myometrium. And both of these causes shift in the placental blood flow from the spiral artery to the larger, deeper radial and arcuate artery. And because of this, the organ becomes highly vascular. So there may be high velocity blood flow in the uteroplacental circulation and leads to formation of placental lacunae. Now on color Doppler, you can see hypervascularization pattern under placental blood flow. Incidence of placenta accreta is increasing day by day, and we all know the attributing cause is the rising number of cesarean delivery. In 1980, it was the incidence was 0.8 per 1,000 deliveries, which has increased to 3 per 1,000 deliveries in last decades. Now, as far as the risk factors are concerned, mostly the most common or the most important risk factor is the previous cesarean section, and it increases with every next section. So if in the first section, the incidence increases to about 0.2%, which further increases to 0.3%. And if it has gone, it is the third section, then it increases to 0.6. For fourth, it becomes 2.1%. Whereas if it goes above that, that is sixth or greater, then it is as high as 6.7%. Also, the risk factor is placenta previa, where the risk is around 5 to 10%. Other risk factors include multiplicity, advanced maternal age, uterine artery embolization, and the cases where there is endometrial destruction, like where there is a procedure done like endometrial thermal ablation, or where vigorous multiple curettage has been done, which has destroyed the endometrium and may lead to abnormal adherent placenta, or where there is uterine pathologies like adenomyosis, bicornuate uterus, submucous fibroid, Asherman syndrome, or where there is a previous history of uterine surgeries like hysterectomy or myomectomy. There are also few biochemical risk factors, but it is not been proved properly. But it has been seen that those female who have elevated first trimester PAPA-A or elevated second trimester maternal serum alpha-fetoprotein and free beta HCG, they have increased chances of PAS. If you see retrospectively, placenta accreta is an iatrogenic 28th century disorder. And this is main, and if you want to prevent it, then you should first and foremost prevent primary, or the primary prevention of the cesarean section should be done, or you should mainly should avoid doing cesarean in the first place. If permission, if there is a, if you have done cesarean, then you must always encourage VBAC or the trial of labor after cesarean. And if there is seen endometritis in postpartum period, then that should be treated properly. You must avoid vigorous curettage, so this will prevent endometrial destruction, and correct surgical technique by closing the uterine incision where you can not include endometrium. So these are the things with which you can decrease the incidence of placenta accreta. It can be very well diagnosed on ultrasonography. So transvaginal scan is more sensitive rather than trans-abdominal scan, especially diagnosing placenta previa at 28 weeks of gestation. Then grayscale or 2D ultrasound has been the cornerstone in diagnosing placenta accreta due to its wide availability and its high accuracy. Now, if there is a presence of anteriorly placed low-lying gestational sac on TVS between 6 to 8 weeks of gestation in the patient who had a previous cesarean delivery, then this should be considered as a higher risk for development of placenta accreta. So you can plan, say, from the first trimester only, that this patient can go into adherent placenta, and you can take very well good precautions to prevent that. Now, these are certain unified descriptors given by the European Working Group of Abnormally Invasive Placenta, which shows what are the findings you will find on ultrasound in 2D grayscale in such adherent placenta. There will be loss of clear zone, there will be abnormal placental lacunae, there will be bladder wall interruption, myometrial thinning, placental bulging, and finally focal exophytic mass, which is very common in Perkita cases. Now, in the second trimester, you can see that there is a loss of retroplacental sonolucent zone, and this finding is almost highly sensitive, about 100%. And in the second photograph, you can see placenta is seen extending up to the serosal surface of the bladder without any intervening myometrium. So this is a very well seen in the 2D scale, 2D ultrasound, and here you can see that it is a Perkita case. Now, in color Doppler, findings which you can find in the placenta accreta is hypervascularity of the serosa and bladder interface. Then there will be peak systolic velocity over 15 centimeter, and there will be markedly dilated vessels over peripherals. So on Doppler, you can see this bridging vessel, there will be hypervascularity, and on the placental lacunae, what you will see, there will be moth-eaten like Swiss cheese appearance, which is very much diagnostic of this type of this placenta accreta syndromes. Now in color Doppler, in 3D Doppler, which is a power Doppler, has shown to be superior in diagnosing placenta percreta from accreta. Here you will see intraplacental hypervascularity, placental bulge, focal exophytic mass, and bridging vessels. And you can diagnose, very well differentiate between placenta percreta from accreta. So transvaginal ultrasonography will show multiple tortuous hypoechoic structures within the placenta, which can be confirmed by 3D ultrasound, Doppler ultrasound. And for Doppler ultrasound for 2D Doppler ultrasound and 3D Doppler ultrasound, you can very well diagnose bladder invasion in the placenta percreta cases. Now the other modality is the MRI, which is usually recommended in such cases where you have done the diagnosis of placenta accreta, but the ultrasound findings of abnormal presentation is equivocal. So inside that case, you can use the help of MRI, or in the cases where evaluation of the posterior placenta is difficult in obese patient, or it can also be in a complementary role in specifically delineating the extent of an ultrasound diagnosed placenta percreta. But before that, you must also know what are the imaging features of normal placentation of MRI, on MRI. So in normal placentation, there will be homogeneous T2 intermediate signal, single intensity of placenta. There will be subtle, thin, regularly spaced placental septi, normal subplacental vascularity. There will be typical triple layer sandwich appearance of the myometrium, and very important, pear-shaped normal gravid uterus with smooth contour. But when it will be a abnormal placenta, or when there is an adherent placenta, in that case, you can see the disruption of the pear-shaped pattern. There will be a dark intraplacental band on 2T weighted image, then abnormal disorganized placental vascularity and focal interruption of the myometrial wall. Also, MRI is useful in showing parametrial extension in which it is not apparent on ultrasound. So this is a very good modality for placenta percreta cases where the placenta has already invaded in a different organ, especially in the bladder. Now, I will be taking few cases just to know that, just to tell you that how these, how we should become wiser, how we became wiser, because these are the few real-time cases which has been dealt with few gynecologists, and how they became wiser one after another. So this was the patient where she was Gravida 3 Plera 1, 24-year female. She was in she was 37 weeks pregnant, and she was presented with leaking PV. There was a history of preterm cesarean section 3 years back, There was no ANC, but she had, in the last time she has visited in the 3rd trimester, and the ultrasound showed single intrauterine live fetus appropriate for gestational age, and the placenta was posterior and low lying. Uterus was open, and the gynecologist opened the uterus, and lower segment cesarean section was done. Baby was delivered safely, but this was followed by repeated attempt to remove placenta. It could not be done. And after some time, they realized that it was adherent placenta, as the patient started bleeding profusely. And this was a horrifying experience for the obstetrician. So in emergency, they have taken the decision of hysterectomy, which was done, but by the time patient already went into irreversible shock and could not be revived. Now, what went wrong in this, and what lesson we can learn from here? First and foremost, any case of previous section, you must have high index of suspicion of placenta accreta syndrome. You must keep risk factors in mind before cesarean section. Try to diagnose before. Try to get at least one ultrasound done before going for cesarean section. Keep blood and blood products ready. And if you have diagnosed on table that it is placenta accreta syndrome, then do not forcefully attempt to remove placenta, which is totally adherent to endometrium or the myometrium, because that will provoke further bleeding and torrential hemorrhage can occur. Plus, along with this, you should have a multidisciplinary approach where you should have a senior obstetrician, because most of the time, these are emergency, dealt by the in emergency and by the juniors. So in that, sometimes it becomes very difficult to diagnose such case. So it should be always done on elective basis, provided if you have some problem, like if there is a placenta percreta type, where you are suspecting that it has invaded in the urinary bladder, then neurosurgeon can be called for. Expert neonatologist and an expert anesthetist should be there, and it should be done where all facilities are available, where you can shift the patient in ICU if it is required. Then you can also try this triple P procedure, which is a novel uterine sparing procedure for PAS, where perioperatively you can do ultrasound for the localization of the superior edge of the placenta. And if there is a time, then you can do pelvic devascularization, especially just before operation by our intra-arterial balloon catheter, if the facilities are there. And finally, there should be no attempt to remove entire placenta. If it is not coming out, then you should leave it as such. Now, these are the stepwise process for diagnosing of PAS after laparotomy. Once you have opened and you have come in across that this is there is something wrong here, you are suspecting placenta acreta syndrome. So how are you going to diagnose such case? So step one is that thorough inspection of the external surface of the uterus and pelvis by frank signs of placental invasion, which include abnormal appearance of uterus over placental bed, where you can see bluish purple appearance with evident distension of placental bulge, obvious invasion of the placental tissue to surface of the uterus with or within invasion of serosa. So if these aspects are clearly seen, then you can diagnose that this is PAS disorder and it has to be confirmed with this. Now in the left side photo, if you can see, there is a uterine window, and here the placenta is directly below the serosa at the uterine dehiscence. So this should not be confused with PAS, but this is actually, it is the dehiscence. So see that there is a normal myometrium here around this. So these dehiscence can be very, very alarming, leading to an incorrect diagnosis of PAS. Whereas on the left side, right side, if you see, there's a placenta percreta showing aberrant neovascularization of on the lower uterine segment, which is going up to behind urinary bladder. So if you are seeing such type of picture, you should be very, very vigilant giving incision on the lower uterine segment. Second step is that if you are not clinically, if there is no clinical evidence of most invasive form of PAS, with no placental tissue seen to be invading through uterine serosa, then uterine incision should be made, leaving placenta undisturbed, and gentle cord traction should be attempted. If you are able to deliver placenta with that, that is fine. If it is not, and if you see a dimple sign, what is dimple sign? If traction of umbilical cord causes uterine wall to be visibly pulled inward in direction of traction with no separation of placenta, then again, PAS should be diagnosed on this condition. Now, when PAS has not been diagnosed by previous two steps, then in that case, you can gently do the digital exploration and can assess the presence of plane of cleavage between uterus and placenta. So if sometimes you are suspecting it is PAS, but it is not that, and very easily placenta separates in that case. So surgical techniques, mainly you should inspect first, see for anterior surface of the uterus, see for the lower segment, see also inspect the lateral surfaces. Then if you see any venous sinusoids, that should be seen and it should not be disturbed. And in such cases, classical or transabdominal, transfundal cesarean section should be done and it should be cut. And through that, you should avoid cutting placenta and should deliver the fetus. And after that, uterus should be closed by whip stitches. So in management strategies, correct assessment of degree of invasion at time of delivery, stratification of the women according to this, precise correlation between prenatal imaging, intraoperative and pathological aspect, because once the specimen has been removed, that should be sent for histopathological examination for confirmation. Now, this is the second case where 25-year female unbooked Gravida 4 para 1 plus 2 with history of full-term cesarean section 4 years back, which was followed by 2 spontaneous abortion where DNC was done, and she came in active stage of labor at 37 weeks. So emergency cesarean section was done, And during operation, it was found that it was placenta percreta with bladder involvement and patient bled profusely. Subtotal hysterectomy was done along with ligation of the blood vessels going into the bladder, but all in vain as the patient vital deteriorated and patient developed DIC, anuria with ARF, and in post-operative period, casualty occurred because of massive blood loss. So how you could have managed this patient better? Again, same high index of suspicion is very important. If you are doing any cesarean section who had a previous section, you must always have this in mind. You must always have ultrasound. That is very important because that can only diagnose whether placenta, what is the location of placenta. So localization of placenta doing cesarean section is very important. All those patients who have a previous cesarean section, they should have regular antenatal checkup, ultrasonography. And if you have diagnosed placenta accreta or PS, then elective cesarean section should be the choice. In percreta patient, if you are suspecting that there may be invasion in the bladder, then you should take help from your urosurgeon, and the facilities for ICU should be there so that post-operative care can be taken up. And very importantly, in all cesarean cases, we are obstetrician and every time bleeding occurs in whether there may be PPH, so it can occur anytime. So blood availability of blood is very important, which should be available 24 hours a day and 365 days a year. So whenever you want, blood should be available when you are going to do any delivery or any cesarean section. That is now should be must. Now, a word about timing of delivery in such cases. So according to RCOG guidelines 2011, they said that the elective cesarean section in asymptomatic women is not recommended before 38 weeks of gestation for placenta previa or before 36 to 37 weeks of gestation for suspected placenta accreta. But by ACOG in 2014, they changed it that elective cesarean section at 34 to 35 weeks of gestation for suspected placenta accreta. Whereas British Journal of Obs and Gynae in 2018, they have come up with recommendation that in the absence of preterm risk, elective cesarean section should be done at 35 to 36 weeks of gestation in the diagnosed case of PAS. Now, cesarean hysterectomy is considered as a gold standard treatment for invasive accreta, although it has high rates of severe maternal morbidity for as high as 40 to 50% and mortality as high as 7%. Now, why it is so? Why this hysterectomy is difficult and why it is so different in such cases? We all know because most of the time it is unplanned hysterectomy. It is an emergency hysterectomy. It is hysterectomy on the very vascular organ, gravid uterus. So, and most of the time it has been done by an inexperienced hand in an emergency time in the middle of the night where all facilities are not available. Also, we have already tried in a repeated attempt to remove placenta, so there may be torrential bleeding. Sometimes you need to go deliver the baby by cutting through placenta, so this all causes massive blood loss. So that should be prevented. So how can you prevent all these things? First and foremost, these type of cases, you should always do it electively. Avoid cutting placenta, go transfundal approach. And if time permits, then preventive surgical or radiological devascularization should be done by placing the balloon catheters or by placing the balloon tamponades. Then these patients have high genitourinary tract injuries, and the reported cases of cystostomy is around 6 to 29% and urethral injuries as high as 7%. So if you have some time and if you are suspecting that you may need to go for hysterectomy, then preoperative stenting of ureters can be preferred because that will reduce urethral trauma. Post-operative management, we must have continuous monitoring of the vitals. She should be shifted in the ICU where all facilities are available. Then monitoring for recurrent or intra-abdominal retroperitoneal bleed should be monitored. then you must also think in the cases where you have conservative, where you have saved the uterus. In that case, you must also see the signs of hypoperfusion. There may be signs of Sheehan syndrome which can occur, and early ambulation. If patient is okay, then she should have early ambulation to prevent thromboembolic complications. Now, this is the third case which was a bad obstetric history patient. She was Gravida 6 para 1 plus 4 with no live issue. She was 36 weeks of gestation with history of previous 1 cesarean section, and before that she had 1 miscarriage, then again 3 DNCs, 3 miscarriage where 3 DNCs were done, and on ultrasound 3D Doppler they found there was complete central placenta with focal placental increta. So in that case we have become wiser, so we have done elective cesarean section at 37 weeks. And once with all facilities available, blood and the expertise, and we have called the urologist also, because in case if it is a Parkerita case, if we need some bladder surgery, or if there is an invasion in the bladder, then that can be taken care for. So luckily that did not happen. There was bilateral uterine artery ligation was done, and gentle removal of placenta was done as far as it was not adherent, and the rest what was totally adherent to the uterine cavity, that was left in situ, and closure of uterine incision was done. Post-operatively, 2 units of blood was transfused along with methotrexate adjuvant treatment. And this patient, both patient and baby survived, and she was successfully managed. And here our priority was to save uterus. So what are the key points during conservative management? You should always have gentle attempt to remove non-accreta portion of the placenta, and do not remove the placenta which is totally adherent to uterine cavity. You can leave it in situ. Preventive radiological or surgical devascularization can be done wherever the facilities are available. This will prevent secondary hemorrhage and placental resorption and help in placental resorption. And methotrexate has increased the placental resolution, although the risk of sepsis, neutropenia, and the secondary hemorrhage is with this, which may sometimes land up into hysterectomy again. But most important conservative management, which should be attempted in those patients who agree to take long-term monitoring, or who have strongly desired to preserve their fertility, and where you have expert hand, and the expert facilities are there, availability of blood is there only you should try this conservative management. There is insufficient evidence regarding the use of MRI and the serum beta HCG for monitoring conservative management, and the use of methotrexate is not routinely recommended. It should be used judiciously whenever required. But I have used in 2-3 cases and I have a good result with that. Now, a word about one-step conservative surgical approach for PS, where we do vascular deconnection of the newly formed feeder vessels and separation of invaded uterine tissue from invaded bladder tissue, upper segment hysterotomy and delivery of the fetus, the resection of all invaded myometrium with placenta in one piece after local vascular control, surgical procedure for hemostasis and myometrial reconstruction in 2 plane, and if required, if bladder has been invaded and bladder has opened, then bladder repair if necessary. Now, what are the follow-up after conservative management? It is very important that during postpartum period, all patients should be seen weekly until complete resorption of the placenta occur, which takes almost 6 months. Ultrasonography and clinical examinations are performed to detect hemorrhage, pain, and signs of infection. C-reactive protein and blood count are checked to help and to choose antibiotic in case of endometritis, which is very important because then the subsequent pregnancy, she can again land up in same problem. What are the RCOG guidelines regarding conservative surgery? Here the women should be warned of risk of bleeding and infection post-operatively. Prophylactic antibiotics will help to reduce infection. Neither methotrexate nor an arterial embolization reduces these risks, so this is not recommended routinely. Even serial beta HCG on weekly basis to check its fall can reassure, but low level do not guarantee complete placental resolution. So you must go for imaging. Ultrasound is must in such cases. So what are the advantages of conservative surgery? It will preserve fertility, which will success rate of about 78%, and it will avoid gravid hysterectomy, which is usually associated with higher mortality, higher transfusion rate, post-operative infection, urethral and fistula formation. But what are the disadvantages with this surgery? Conservative surgery, there may be failure rate of almost 18%. There may be chances of infection if you have left the placenta inside the uterine cavity. There may be bleeding, DIC, and sometimes you may need to open this patient again and you have to do hysterectomy afterwards. What are the effect on subsequent pregnancy? There may be recurrence of placenta accreta in about 16 to 28%. Blood transfusion will be needed in 90%. Fistula formation in about 3 to 3.3%, and uterine rupture in 3.3%. Now, what about role of uterine artery embolization? So whether it is good or bad, though uterine artery embolization is latest interventional technique in case of accreta syndrome, but it's not available in many of the setups. So I think old age uterine artery ligation, we must all master in that technique, so that because that is life-saving. And also the role of interventional radiological procedure is not that, although it looks promising, but still further researches are required. And even our RCOG does not recommend it routinely. Now in the end, I will just tell you about the the deadly Ds of accreta, which is very important. You must always keep in your mind whenever you are doing any cesarean section. First and deadly D is a delay in referral. When you are not referring, when you are thinking that you are able to do that case and you don't have full facilities, you should not delay. Such cases should be referred in higher center where all facilities are available. Where you have delayed the cesarean and then it has landed up in emergency, so it should not be done emergency. It should always be elective. And when you have delayed the decision for hysterectomy. So these are three delayed which should not be done, because that will act deadly for accreta cases. Then deficiency is what? When there is deficiency of time availability, extensive adhesions, no time for preoperative devascularization, so that should not be there. When there is a deficiency of blood and blood products, when blood are not available, in that case you should not try doing such cases. When there is deficiency of ICU beds, you don't have ICU facility and still you are proceeding with such cases, it should not be done. And deficiency of multidisciplinary senior team, which is very, very important. You should have experienced obstetrician, an experienced anesthetist and neonatologist. Along with, you can take help from your urological surgeon or any pelvic surgeon. So if you ask me what is the worst obstetric complication which we see, I think this is one of the worst obstetric complication which we may come across any time in our day-to-day practice. So to overcome this, you should overcome this and save life by preparedness. How you will prepare it? If you are having a repeat section patient, you must always call her for antenatal checkups. And if she has not come for that, at least you must get her ultrasound done. That is very important for the localization of placenta. She should, anemia should be corrected. And plus patient should be counseled properly, which is very important, because most of the time patient feels that she is all right. And suddenly what has happened? Why so much problem has occurred? So patient should be counseled properly and regular follow-up is important. Then you must have expertise. Only when you have expertise in uterine artery ligation and hysterectomy if required, then only you should proceed such type of cases, and aptness to refer the such patient and aptness to look after that whenever the need is required. It should be on time. Otherwise, if you are losing time, then maybe you will not be able to save the patient. So this is very important, because if you can save the patient, you can save your skin also, because in this era of medical legal cells, we must know. Many a times patient will come to us and will ask that why patient was all right and suddenly what has happened, why she has gone in such type of problems. So we must counsel our patient properly, and all facilities should be available. Then only you should proceed to such cases, which is real nightmare for all of us. So thank you so much for patient hearing, and I'm very sorry for this type of problem. Thank you so much.
Pratibha ma'am, thank you so much for this really very practical tips, your live cases. Thank you so much, ma'am, for this wonderful, lecture. It's really a very interesting one, and really we learn a lot from that. So before we start, I would like to invite Prachi ma'am, the chairperson.
Prachi is here. Yeah,
think...
Prachi, unmute yourself.
Unmute yourself.
Yeah, Prachi ma'am, please unmute yourself.
Yeah. Yes. Thank you. Before I start, I would like to thank Dr. MC Patel, sir, for organizing this very important CME on this, what can I say, a very nightmarish subject of adherent placenta spectrum and abruptio placentae. Dr. Pratibha madam she has elucidated on every point. I cannot say that she has left any point. All points have been thoroughly covered. And just few practical points I would like to say is that it is very important for all gynecologists to do, we have to learn to do ultrasound ourselves. Because even from the first trimester, we can start to suspect. If you do it yourself, you will be able to realize that this, because many ultrasoundologists, they do not understand the significance of, because the increased cesarean section now, scar ectopics are coming, adherent placentas are coming. So we have to always keep in mind, and it is always a very plus point if we can do the ultrasound ourselves. Also, especially in cases of placenta, if the posterior placenta is placed, then we can many times miss that the patient has accreta, because anterior placenta we can diagnose by ultrasound. If the patient is obese and the placenta is posterior, in that case, many times accreta can be missed. We have to keep that in mind also. And this is no child's play. Of course, the cesarean has to be well planned. I think all of the topics have been covered, and thank you very much, Pratibha madam, and thank you, sir, for allowing me to join this CME. Thank you.
Thank you. Thank you so much.
Thank you. Thank you, speaker and chairperson. So, Suman ma'am, before actually we go to next, I would like to take a comment from Dr. Asha Jain ma'am. Ma'am has joined. Asha ma'am, are you there?
Yeah, she is here.
Yes, I'm there.
Yeah, ma'am. Your comments for this whole lectures, the placenta about the placenta previa, this placenta syndrome, and the medical legal. In very short, yeah.
Thank you, Apurv. So, I've heard all three lectures, very senior faculty speaking, like the best, Dr. Kumudni, Dr. Pratibha, Dr. MC sir. So basically, what I would like to add is that placenta previa now is becoming more and more an iatrogenic problem. And it is the placenta previa that leads to placenta accreta most of the time, because most accretas are anterior or placenta previa. So the thing is, we as doctors are being questioned about the number of cesarean sections also, and that leads to medical legal problems. So we need to sort of really be judicious and record everything, why we are doing every cesarean section. And we need to, what Dr. Prachi said right now is what I would like to put forth for everyone, that you need to look at the placenta yourself. right from the first trimester. If a patient has a history of 2 or 3 cesareans and you see that the implantation is in the lower pole, near the scar, anterior, then you can give that person an option of a termination of that pregnancy compared to carrying it to term if she already has live pregnancies. So we just need to be sort of more alert, doing our scans ourselves. And the lectures were fantastic. They've covered A to Z. So I don't think I really can add anything more to that. Thanks a lot for having me in. Thanks.
Thank you. Thank you so much, Asha ma'am. So over to you, Suman ma'am, for connecting the last. Yeah.
Thank you, Apurva, and thank you, Pratibha, for your very elaborate presentation. And really, as Prachi said, nothing was left.
Thank you.
It was really an eye-opener for all the viewers. I think they will take a lesson to be very, very careful while dealing with a case of placenta previa. And even doing cesarean, even first cesarean, they have to be very careful. So now we move on to a very exciting panel, which all are waiting, and we have seen all the panelists preparing. And the topic is very, challenging. That is troubleshooting in abdominal placentation. And so this, I'd like to welcome all our moderators. So can I have the CVs and the experts also? We need the CVs. I think where has he gone?
Vashuji, yeah.
Yeah, started. Thank you. Yeah.
For panel discussion, please.
Or panel, the last one. Keep on moving.
Just give me a second, ma'am.
Yeah. Take your time, no problem. After that, yeah. I need to have the move it. Yeah. So for the moderators, we have Dr. Vibha Verma. She is Vice President of Muzaffarpur OB-GYN Society. Can I have her CV in detail? Yeah. Dr. Vibha, she is also a very good friend of mine. She is Treasurer IMA Muzaffarpur, Joint Secretary of AOG-SBJ, and Senior Consultant Gynecologist at SKMCH Muzaffarpur, which is in Bihar. So next, Dr. Kumari Sweta. She is the other moderator, co-moderator rather. She is member of IMA, member of FOXY, and Senior Medical Officer in the Health Department. And she is Consultant Obstetrician and Gynecologist at Panchsheel Mother and Child Hospital at Begusarai. So the CV of the experts, please. So, our experts are Dr. Sneha Bhuyar Madam and Dr. Rekha Rajendra Kumar. Can I have the CV? Dr. Sneha, we have already given her introduction.
Yes, Dr. Suman, you can go ahead.
So we move on to Dr. Rajendra Kumar Madam. Rekha Rajendra Kumar Madam. She is practicing gynecologist for the past 30 years, Vice President of Bangalore Obstetric and Gynec Society. She is Chairperson Infertility in ART Committee.
Can you please zoom it little? Yeah.
And we have been invited as speakers, chairpersons, panelists to more than 500 state, national, international conferences. She is live member of this Bangalore Obstetric Society, FOXY, KISAR, ISAR, IAG, PCOS Society of India, IFS, etc. And there are a lot of papers and publications to her credit. Case report, original articles, poster presentation in Aishri conference in 2021, more than 100 radio and television talks, 40 newspaper articles, all on women's health. So welcome all the experts and all the moderators and co-moderator. So I would like the moderators to introduce our panelists. So can we have the CVs of all the panelists? So Dr. Vibha.
I think Suman ma'am, we can just have a one or two line introduction.
Exactly.
Yeah.
Even for the experts, I would request you to be very short, I think, Suman.
Okay.
Okay.
I didn't
Yeah,
take much time, Dr. Sneha. I didn't describe you. Only Dr. Rekha was not introduced earlier. So Dr. Barsa Sinha, he is consultant OB-GYN at Astha Nursing Home, Bhagalpur. Dr. Roli Bharti, she is consultant gynecologist from Bhagalpur. Dr. Supriya Narayan, she is a specialist gynec and from Darbhanga. Dr. Ashu Rani, she is consultant gynecologist at Ganpati Nursing Home, Muzaffarpur. Dr. Sadhna Sinha, secretary of Muzaffarpur OB-GYN Society. Dr. Sunita Sharma, she is vice president, Magad OB-GYN Society. Dr. Ruma Yadav, vice president from Bhagalpur OB-GYN Society, and Dr. Zamurad, senior resident at Darbhanga Medical College. So welcome all of you. So let us move on to the panel discussion. So it's all been. No. So
he's unshared. Yeah.
Stop sharing. Stop sharing. Yes.
Over to moderator Vibha ma'am. Yeah.
Yes.
Yeah.
Yes, I hope the panelists are ready.
Very much ready they are, I think.
Yes. Ready.
Yeah, we are also ready, ma'am, to learn from you.
We are also ready.
To start with, I would like to have first question.
Ma'am, is there any PPTs?
Yeah.
Yeah, okay.
Question 1, should we screen women for placenta previa? If yes, then at what gestational age? And how to follow up? This question will go to who's the first one in the panelist?
Give it to me.
I think Dr. Varsha is there.
Yes,
Yeah.
Dr. Varsha, this question goes to you.
Is Dr. Varsha is there? I don't think so.
No, she is not here.
Then can I answer this question, ma'am?
Can I answer this question?
No, this will go to second one.
Yeah, ma'am, I was the second panelist, so I told that if she's not there, then can I answer the question?
Okay,
you can.
Okay, we should definitely screen for placenta previa because we all know how complicated it goes if it remains unscreened. So for this, ultrasonography is the most trusted modality that we can go for. And screening should be done. The first screening should be done when we send the patient for the anomaly scan. That is around 18 to 20 weeks. And if at that time we find that the placenta is low lying or there is a placenta previa which is entirely covering the internal os, then we can go for another scan at 32 weeks. And there again, if the patient remains asymptomatic, and again, if we find that the placenta is low lying or their placenta previa is there, then a repeat scan can be done at 36 weeks if the patient remains asymptomatic and she doesn't complain of any bleeding or any history. So we can go for 3 scans to diagnose the placenta previa. The last scan can give us a lead about the treatment modality, how we should proceed about how we can get about the cervical length and all those things, so that we can prepare ourselves how we should proceed for the further taking care of the patient, whether when the cesarean can be planned or hysterectomy may be needed in that case.
I think most dangerous position of placenta previa is anterior behind bladder.
Yeah.
If it is present there, I think it is most dangerous. Central, I think it is even more dangerous than central one. We have done so many cases of placenta invading bladder and the difficult dissection of bladder and lower segment of uterus. So I think placenta in lower segment, and that too anterior behind the bladder, is most dangerous position. And that should be followed up. Next question. Question 2. What are the risk factors for placenta accreta spectrum PAS? How can PAS be suspected and diagnosed antenatally? what you see in ultrasonography that you suspect that it is going to be accreta?
Hello, ma'am.
Yes.
Ma'am, there are many risk factors for placenta accreta, like previous cesarean section. As the number of cesarean section increases gradually, the risk of placenta previa pass, and the other risk factors are multiparity, increased age, smoking, and ma'am, repeated handling of the uterus like curettage, and ma'am, implantation of placenta over septum, any septum, and ma'am, it can be suspected, as ma'am has said, very early in the gestational period, after doing a transvaginal scan. If the GSEC is implanted low in the lower segment, then it can be suspected that this pregnancy may proceed to pass. And at the time of the anomaly scan, it can be suspected if placenta is in the lower segment or covering the internal os, and it can be followed at 32-34 week, and after then 36 week, if this is resolving or remaining as the past, so that we can prepare ourselves for the further management.
Risk factors, please. Risk
Yes, ma'am.
factors are previous LSCS, previous extremes of phase, APH, ART.
Yes, ma'am, ART.
जो IVF हो रहा है, उसमें बहुत ज्यादा हो रहा है placenta previa और
multiple pregnancy.
Yeah, लेकिन I would like to add कि if the placenta is in lower segment, आप placenta को recognize कर सकते हो. There is a line of cleavage you find between uterine wall and placenta, and that should be seen clearly. And if you put color in that, और अगर वो कलर डॉपलर से आप देखते हो और अगर आप उसमें आपको कोई प्लेन ऑफ क्लीवेज नहीं मिल रहा है, नीटाबॉक्स मेम्ब्रेन नहीं मिल रहा है, देन इट इज प्लासेंटा एक्रीटा. आप बहुत पहले से जान सकते हैं. कहाँ 36 वीक्स तक जाने की कोई जरूरत ही नहीं है. एंड आपको उसी समय से प्रिपेयर होना है कि हाँ भाई आपको कहाँ कराना है ये सर्जरी और आपको कितना ब्लड लगेगा, और आपको एक सबसे सीनियर गायनेकोलॉजिस्ट और ऑब्स्टेट्रिशियन ही आपकी सर्जरी करनी चाहिए, एटसेट्रा एटसेट्रा. ऐसा नहीं है कि 36 वीक तक एक्रीटा का डायग्नोसिस नहीं होता है. Nowadays we are getting patients 32 weeks, 30 weeks with diagnosed placenta accreta with previous LSCS. Even last Tuesday we have done a placenta percreta case, very dangerous, and we have done a hysterectomy, and by God grace she is saved after 4 blood transfusion. Next question. Why there is abnormal placentation in preeclampsia? Sadhna-di, this is for you.
It is due to hypoxia and abnormal invasion. Abnormal placentation is due to incomplete trophoblastic invasion.
Yes.
Anything more you tell us?
Yes, it is due to hypoxia, abnormal invasion of cytotrophoblast into the spiral artery, and more due to and release of those chemicals there in response to that in cases of preeclampsia patients.
Preeclampsia.
Yeah. So there is abnormal invasion and release of all kinds of notorious chemicals there. And that leads to hypertension and inadequate blood supply because spiral arteries are not properly invaded, and there is IUGR later. You will see a small size of placenta, etc., etc. So the question 4: is there any role of MRI in placenta accreta spectrum? Who is the 4th one?
Myself.
Oh, Ashurani.
Dr. Ashurani.
Ashurani also does ultrasound regularly. So Ashurani.
Yes.
Yeah.
Yes, MRI is used to complement the ultrasonography to assess the depth of the invasion of placenta and the lateral extension to the bladder and the parametrium, especially in case of posterior placenta. It may also invade the pelvic structures. So MRI is very useful in diagnosing that.
Yes, with MRI you can decide that what will be the point of your incision, because sometimes we don't know up to how much height placenta is extending.
But usually a classical incision, usually on the away from the placenta, either fundal or classical incision, we should deliver the baby.
Yes, but MRI is a little costly and many patients won't afford it. So this is a drawback. Even at medical colleges, it's not done free.
Yes, that's true.
Yes, Dr. Vibha, can I make some comment here?
Yes, definitely.
Yeah. So, madam, actually, just pertinent to the question that if, as a routine, we do not need MRI to be done for the diagnosis and management of placenta accreta spectrum. If you have a good resolution sonography machine and a good expert sonologist, in majority of the cases, the diagnosis and even the extent, you can even map the placenta. But yes, in very obese women, especially with the posterior placenta, as Dr. Ashu has also very rightly pointed out, we may need to go for MRI. But given an opportunity and considering the cost efficacy, I think ultrasonography may suffice for diagnosis of the condition. I think there's some echoing of the sound. So MRI only if at all you want to know the depth of invasion and lateral extension. And when you want to plan the triple P procedure, I think that's what is most needed. Thank you.
Thanks.
Please, someone is singing. Next question. Wasit, next question. Where should a woman
with past be cared for when delivery will be planned? This question is for Sadhna, ma'am.
Yes. When a probability of pass is raised, it should trigger an early referral to a tertiary care center. Diagnosis should be made before 30 weeks to plan an elective delivery at 35 to 36 weeks with steroid cover. There should be facility for blood transfusion and NICU.
And the delivery, ma'am, when delivery will be planned?
We planned at 35 to 30 and at tertiary center, not at ordinary nursing home. There should be very senior and obstetrician should be there. Facility of blood transfusion should be there. Facility of NICU, ICU should be there.
And multidisciplinary approach. Now, next question. What should be included in the consent form for cesarean section in women with PATH? This question is for Dr. Sunita Sarma, ma'am.
She's not here.
Now, Dr. Romayado, ma'am.
Roma ma'am, please unmute yourself.
Good evening all. Since this is a difficult situation both for the patient and for the obstetrician both, and there must be a clear-cut counseling to the patient, and a consent form should be taken before taking the patient to the OT. So, in most of the cases, the placenta accreta has been diagnosed during antenatal checkup, and we are knowing that we are going to handle a difficult situation. And in this case, there is the chance of a massive hemorrhage, so blood transfusion or blood products is necessary. There should be a consent form about the transfusion of the blood and the blood products, number one. Number two, if we can't remove the placenta and there is a need of removal of the uterus, cesarean hysterectomy is needed at that time, then the consent form must be there for the organ removal. We are going to remove the uterus, and for that the consent is very much necessary. Third thing, if the placenta is invaded, increta is invading the urinary bladder, there may be a chance of damage to the urinary bladder, and there may occur the fistula. And in that very situation, after the operation is finished, when the patient is discharged, there may occur the VVF or anything, any type of fistula, then again we will end up in the court. So the clear-cut consent form about this type of mishappening may occur, that should be counseled to the patient and clear consent should be taken. And everything related to the difficult situation, the morbidity, the mortality should be well explained to the patient, to the attendants, and consent form should be taken.
There may be chances of DOT also.
Yeah, ma'am. Yeah, ma'am. There may be, and for this the counseling is the best.
And about the neonatology also, that you're shifting the baby to the NICU.
Yeah.
For of the mother.
Yeah, that should be because the baby is premature, and we are doing the cesarean section at 34 to 35 weeks of gestation. There may be a neonatologist, and referral is must. That should also be counseled to the attendants.
Next question, please. What anesthetic is most suitable for PAS?
मेरा कौन म्यूट कर दे रहा? What anesthetic is most suitable for placenta accreta spectrum?
Regional anesthesia is most suitable for PAS, but if needed or if anesthetics feel that there is a need for general anesthesia, then the regional anesthesia can be converted to general anesthesia. But the regional anesthesia, in that there's a blood loss is less than the regional than the general anesthesia, so regional anesthesia is preferred, ma'am.
आप बताइए.
हेलो.
हेलो. रीजनल में आप कर रही हैं प्लासेंटा प्रीविया का, उसको जनरल कब करने की जरूरत हो जाती है एनेस्थेटिस्ट को?
Ma'am, when the vitals goes very unstable, like when the saturation falls, then there's a need of general anesthesia, and we have to provide her with more of the oxygen and yes, ma'am.
More oxygen and more ventilation is required.
Yes, ma'am. Then there is a need for, so that we can control her respiration also along with oxygenation, and it is seen that, ma'am, when it is converted to general anesthesia, then something happens or something good for the patient is there.
Okay. Have you seen any placenta accreta surgery?
Yes, ma'am. I have done in the last week in DMCH only. Placenta accreta, it was there, and I have done a cesarean hysterectomy, and 2 units of blood was transfused intraoperative, but the anesthesia was regional only.
Yes. Next question. What surgical approach should be used for women with placenta accreta? Ashu Rani.
Yes, in case of placenta accreta, we have to go above the placenta and take the baby out first, and we should see if the patient is hemodynamically stable or not. If the patient is stable, then we can leave the placenta in situ and do a cesarean hysterectomy. Or and if the patient is not stable, and then we can do a partial excision of the uterine wall and with the placenta, and the uterus can be closed. And this patient should be managed in a very specialized center who have got expertise in management of this placenta accreta spectrum, where all the urologists and expert surgeons and anesthetists and all the team, multidisciplinary team is available. There only we can do that.
Yes. Next question, please.
A liberal incision, a longitudinal incision over the abdomen, and a liberal transfundal incision to remove the baby. That can be done.
Yes. Yes.
Question 9 is, when is interventional radiology indicated? This question goes to Sweta.
Yes, ma'am.
Given
This
the
question, this question is
question, Abhi.
When is interventional radiological indicated? This question is for Sadhana Sinha, ma'am. Next.
Okay. Prophylactic uterine artery embolism can be done to prevent intrapartum blood loss in high-risk patient.
This is done for the ladies who need future fertility.
Fertility, yes. Yes, of course. This is indicated if the patient requires future fertility.
And in Bihar, it is being done at IGIMS, and they are using nickel with tungsten, and their pellets they are using to block the blood vessel. Have you seen any time the internal anterior division of internal iliac artery ligation?
No, I haven't seen it.
We have seen and we have done it in our unit. I think 6 months ago, for a patient who was desirous of future fertility and had placenta accreta and was bleeding. We managed to save her, but with great difficulty. Question number 9. When is this ye to ho gaya. Next question.
Yes, undiagnosed and suspected.
Excuse me. There's one question. Dr. Biva, will you please make it clear? You did in cases of patients who require future fertility, you did this. Then how do you remove the placenta? It is accreta. Then what is the next procedure? What is the next steps you have taken? Just explain it.
It was placenta.
You have done the embolization.
Yeah, it was embolization. We are not doing embolization. IGIMS, but we have done only anterior internal iliac artery ligation for one case where PPH was not stopping after cesarean of placenta accreta.
Oh, just for the massive bleeding.
Question number 10. Undiagnosed and unsuspected placenta accreta spectrum. If opened, what to do? This question goes to Sweta. Decide the.
Yes, ma'am. This question is for Dr. Smita Sharma is not present. Roma Yadav, ma'am, please.
If the Dr. Smita Sharma is not here, if the undiagnosed and unsuspected unexpected case of this placenta accreta syndrome, if open, and if there is no facility for blood transfusion, if the obstetrician is not competent enough to do the cesarean hysterectomy and handle the situation, better to close the abdomen and refer to the higher centers, because it is a multidisciplinary approach should be there. There should be the presence of the blood there should be the ability of blood transfusion, blood and blood products transfusion, and organ removal like the cesarean hysterectomy. The obstetrician must be competent enough to do the cesarean hysterectomy. And if there is bladder invasion, there must be a presence of urosurgeon. So in this very case, if we are not able to handle this type of situation, better to close the abdomen and send to the higher centers.
Yes, very correct. Last question.
Last is your case, ma'am.
Yes, and it's true case.
Yes, ma'am.
You explain us.
Yeah, it was I think 6 months happened of this case. It came, a lady came at SKMCH at 9 a.m. The lady was 29 years old. She was para 2, previous 2 cesarean section, and she has one alive child, and she was a daughter, and she presented at 34 weeks. She was referred from 4 places. First from her own obstetrician, then to here a KDKM hospital, then to someone somewhere else, and lastly to SKMCH. She was bleeding heavily, and her clothes were fully soaked, and her hemoglobin was 6 gram%. She was report of placenta previa and accreta. So explain what would have happened. She was not ready for hysterectomy as she has only one alive girl, and this baby was dead. So this is a true case, and let us know your answer, and then I will tell you what happened.
It is a very difficult one.
Ma'am, in this case, ma'am, may I take this case?
Yes, yes.
Yes. Ma'am, in this
You
case.
tell us. You tell us, Viva, you have handled this case. You tell us.
No, no, let madam say something.
Yeah, since in this case the hemoglobin is 6 gram%, so there should be the blood should be managed. Blood should be managed, and 2, 3 or more BT may be required for this case. That should be managed, and since she wants the further pregnancy, fertility should be preserved. As you already said, that uterine artery embolization, which is only done at IGMS, that we can't do. And then in this very case, the internal iliac artery ligation can be done. Is it so, ma'am?
No, she refused for hysterectomy on the table, and we managed to control the bleeding with great pressure on her lower segment.
Aortic compression.
And we managed to control the bleeding at that time only with great pressure with dry tetra on her lower segment. And as she didn't give us consent for hysterectomy because she has only one living child, so we closed the uterus, and with tetra packed inside the lower uterus, we shifted the patient to ICU. And after 2 hours, she again started bleeding, and then we have to take the patient again in the OT, and there was nothing choice left for her, and she has to give the consent for organ removal, and we have to do the total hysterectomy of this patient, and she survived after so many blood transfusion. She had secondary suture also because tissues were quite devitalized and very fragile till that time, because she was bleeding from a day before, and she was traveling from here to there, and she was cared by us, and it was very difficult to save her, but she was
Patient
saved.
बच गई ना?
जी
Patient बच गई ना?
बच गई.
Hats off to Viva.
Yes, very good.
Nicely managed. Hats off to Viva.
With this, we come to end of this discussion, and I now want something from Sneha Buyar madam to add. What should we do so that we get some better result and better management?
I think, Dr. Vibha, you have very nicely conducted the discussion as far as the practical case approach is concerned. So what message I would like to give from my side is definitely, as Dr. Asha has said, yes, we have to cut down on primary cesarean section. We have to just what indication it has. Secondly, you should have a very high index of suspicion. So right from early pregnancy, maybe at even 11 to 13 weeks, you can diagnose the, placenta previa and maybe even accreta, as you have rightly pointed out, the absence of the sonolucent zone. Absence of the sonolucent, retroplacental zone. So right from that point of time, you can catch this. Suppose this patient has decided to continue this pregnancy, we have one more opportunity if it is not diagnosed earlier. 18 to 22, when we routinely do the target scan, that is a right time, to catch this condition where you have the very confirmed diagnosis of absence RP zone, and of course whether you have excessive vascularity of the lower uterine segment, where you have the loss of interface between the myometrium and the bladder. So that is how you can diagnose it. As I have already said, the expert sonologists with good resolution sonography should be all that suffice for the diagnosis. But yes, in difficult cases, obese and the posterior placenta, you may require MRI. Once you diagnose this case of placenta previa, that to accreta, you have to first and foremost, you involve the patient and the relatives in the discussion, and you have to take informed written consent. For what? First and foremost, even though we plan to continue this pregnancy and we try our best, any point of time she can bleed excessively and we may not reach the expected period of gestation. So wherever possible, we need to hospitalize this woman. We have to arrange for blood and blood products. We have to keep everything ready, and informed consent always ready. Secondly, if at all she has warning hemorrhages, basically you have to warn her about the various activities, not to have intercourse, not to have internal examination, not to lift heavy weights and strenuous exercises, all these things. Traveling, of course, she has to avoid. If at all we feel that now we are carrying her forward, we have to prepare this patient so that we give antenatal steroids and magnesium sulfate for neuroprotection, so that we can at least try and reach 34 weeks. And whenever we decide it has to be elective cesarean section, first I will say it has to be an elective procedure, but elective cesarean with obstetric hysterectomy. The lady has to accept, unless if it is a primigravida, then we will give her some more options maybe, but in a multi-para or multi-gravida, I would say it has to be elective cesarean section with obstetric hysterectomy, and she has to be informed about the possibility of the complications, intraoperative trauma to other viscera, excessive bleeding, and of course the need for blood and blood products. Any complications she can land up into. When we are planning this procedure, it has to be elective, so that we have senior obstetrician and his team, senior anesthetist and his team, blood bank, and of course the oncosurgeon or urosurgeon, because sometimes, as you have said, the percreta, you need the ureteric stenting also. So we have to have the urosurgeon or oncosurgeon, and of course interventional neurologist, interventional radiologist, if available, that is the best. And this procedure has to be done in the tertiary care unit. Of course, post-operative care, and all of you are expert. As previously described, leaving the placenta inside with in situ, giving methotrexate has no role. Evidence has enough proved that it is not going to help us. It's a hanging sword on your neck. Any time in the middle of the night, the patient will bleed torrentially, or she can even go for septic shock. So I think conservative management doesn't have any role in this. It has to be elective obstetric hysterectomy. And of course, the rest of the procedure you have very well explained also, that it has to be a fundal or a classical cesarean section. There should be absolutely no attempt at removal of the placenta. So very, very well clear-cut messages are given by this panel. And I congratulate all of you, all the panelists and both the moderators. Thank you. Over to you, Dr. Vibha. You can continue. Yeah, you can make some comments. Please unmute yourself.
With this, we came to end of this session, and I hand over this. I hand over my to Suman ma'am to conclude the session.
Thank you, Dr. Vibha and Dr. Sweta, for a very enlightening panel on such a difficult topic. You made it so simple for all of us. And would you like to ask one-line questions from your panelists, or it's over? Vibha?
It's over.
It's over.
Yeah.
Fantastic job, all the panelists and the moderators. So
we have
round of applause for all of them.
Yeah, we have posted, I have posted all the case of Akrita surgery in OBGYN discussion. That is a page on Facebook. I think I have posted more than 10-12 cases with picture.
Very nice. We like to see it sometime.
Dr. Vibha, I would like to add one point here as the expert panelist, if you don't mind.
Yeah.
Yeah, this is regarding the cases we sometimes in the very first trimester, there is a cesarean scar pregnancy, like the previous cesarean, and now the pregnancy on the cesarean scar one has to watch for. So the obstetrician and the sonologist has to be vigilant and careful right from there, because most of these cases where the scar pregnancy has occurred do invariably land up in placenta accreta.
Yes.
So that is one thing I would like to add. And second thing is as all of you, nothing much to say, all of you have told the high degree of suspicion, and right from the beginning, these kind of patients have to be handed over to the institutional care, not the last minute, like though not bleeding at 30 weeks, I can't hand over to the institution, go to the institution, till now I have managed. No, right from the beginning, because her anemia has to be corrected, all the other multidisciplinary doctors have to be sensitized, etc., so that you really plan it so well, and it's a elective as well as the rest of the things also, like morbidity, mortality, neonatal problems, everything is very much taken care of. So this is what I just wanted to add to whatever has been already told.
Yes. Thank you, ma'am.
Yeah.
So, Dr. Apurva, I think it's right time to give vote of thanks.
Yeah, already. So after this, really a wonderful discussion, and I think this is A to Z of everything about the placental abnormalities. So after all this wonderful session, now it's the time to say goodbye, and before that, vote of thanks. So at the outset, I would
Apurva, let's have permission from Dr. MC Patel, sir.
Yes, we can.
And good job, Dr. Suman and Apurva.
Thank you so much. Madam. So at the outset, I would like to thanks to the person behind this whole program. This whole program will not see the day of a light without our respected Dr. MC Patel, sir. And today it's 109th edition. So itself shows that how popular it is among all of us, the obstetricians who are the hardcore obstetricians. And sir is always choosing a topic which is really a troubleshoot to all of us. So thank you so much, sir, for planning this program and bringing out this topic so beautifully and wonderfully. And the convener of the program, very dear Dr. Sneha Bhuyar ma'am and Dr. Asa Jain ma'am. Our chief guest, thank you so much, Dr. Rangila Sinha ma'am, guest of honor, Dr. Anita Singh ma'am, and Dr. Bina Sinha ma'am. All the chairpersons, Dr. Anju Turier ma'am, Dr. Bharat Prasad sir, Dr. Ramadhir Tiwari sir, Dr. Maya Shankar Thakur sir, Dr. Rekha Jha ma'am, Dr. Prachi Singh ma'am, Dr. Kavita Varnawal ma'am, Dr. Prabhati Keshri ma'am, Dr. Lata Sukra Dwivedi ma'am, and the wonderful speakers, very respected Dr. Kumudni Jha ma'am, our own Dr. Pratibha Singh ma'am, and respected Dr. MC Patel sir. The moderators, Vibha Verma ma'am, Dr. Shweta Kumari ma'am, and the expert comments from Dr. Sneha Bhuyar ma'am, Dr. Rekha Rajendra Kumar ma'am, the coordinator, Dr. Kalpana ma'am, Dr. Jyoti Banglowala ma'am, and the wonderful panelists, Dr. Varsa Sinha ma'am, Dr. Roli Bharti ma'am, Dr. Supriya Narayan ma'am, Dr. Ashu Rani ma'am, Dr. Shadna Sinha ma'am, Dr. Sunita Sarma ma'am, Dr. Roma Yadav ma'am, and Dr. Jamura. And my wonderful co-moderator, my senior, very lovable, Dr. Suman Sinha ma'am. So thank you so much. And this is really without help from our technical partner, that is the Core Connect, that is from the Corona Remedies. Thank you so much for providing us this wonderful platform. So thank you so much. Thank you so much to all the viewers who are stick even after 4 hours to this screening and listen and learn a lot from our own very expert. So thank you so much. So say goodbye so that we will meet again.
Goodbye.
Thank you sir.
Thank you, sir. Thank you.
Thank you, sir.
Thank you. Thank you.
And thank you so much, sir. Pranam Patel, sir.
Thank you all the faculties. Thank you, everyone. Wonderful being with you.
Nightmarish topic and sensitized everybody. Thanks for that.
Thank you, MC Patel, sir, for the opportunity.
Thank you.
Definitely.
Thank you, sir.
Pranam, sir, and good night, sir.
Good night, sir.
Good night, sir. Good night, all of you.
Privilege to have you all on board. Very proud to.
Thank you, ma'am.
Thank you, Suman, ma'am.